Good morning and welcome to the first India Immunization Summit 2021, an initiative of Integrated Health and Wellbeing Council to understand the challenges of immunization and how India can prevent millions of deaths due to the lack of the right vaccine at the right time. I am Kamal Narayan, CEO of ISW Council, India's premier institution for health awareness, advocacy, and behavior change. There can be nothing as unfortunate as death caused by a preventable reason. Immunization or developing immunity with the help of vaccines is deemed one of the most effective and economical ways to protect lives and futures, especially that of children. According to UNICEF, missing routine immunization can be life-threatening for infants, and if children were vaccinated adequately, 1.5 million deaths could be avoided all over the world. Nearly 1 million children in India still die before their fifth birthday, and about one of every four of these deaths are caused by pneumonia or diarrhea. A look at fourth edition of National Family Health Survey 2015 and 16 may tell us why. The survey results show only 62% of infants till the age of 2 years being deemed fully immunized, though the latest and the fifth edition of NFHS registers remarkable improvement in the percentage of fully immunized children. The disparity continues from state to state and between various socioeconomic groups. And the ongoing pandemic has only seemed to have made it worse. If doctors are to be believed, the scare of COVID infection has affected new parents so much that immunization dropped drastically. The UNICEF says more than 3 million children missed out on the first dose of DTP vaccine in India in 2020, which is 1.6 million more than what was the number in 2019. Talking about the adult immunization, it has become much more common since the vaccines for COVID-19 were made available. However, not many are aware of the diseases like hepatitis or cervical cancer that can occur in absence of a protective vaccine. Infectious diseases like pneumonia kill 40,000 Indians every year, and yet many of us remain out of the safety guard of pneumococcal vaccine. In absence of a holistic vaccine policy for adults, India faces a tremendous challenge in addressing their vaccine hesitancy. It is among the top factors that are affecting the ongoing vaccination against COVID-19 as well. So the summit today is an attempt to initiate a brainstorming session to understand why simple preventive steps like vaccination are so difficult to implement in India and how we can secure the lives of millions of Indians by getting them vaccinated. And to strengthen India's support or resolve to make itself immune to diseases, we have a galaxy of speakers who have made the maximum impact in the area of immunization. So let me welcome our esteemed panelists today. We have Dr. Rakesh Kumar, former Joint Secretary, Ministry of Health and Family Welfare, Government of India, and also former Senior Deputy DG ICMR and Additional Country Director of UNDP, India. Trained as a Doctor of Medicine at AIIMS, New Delhi, Dr. Kumar has been a member of the Indian Administrative Services since 1992. Dr. Kumar has successfully led the polio eradication, maternal and neonatal tetanus elimination, and has been architect of world's largest immunization program, Mission Indradhanush. He also conceived and implemented electronic vaccine intelligence network EVIN, an innovative technological solution commissioned by the government of India to strengthen immunization supply chain system across the country. This robust system helped ensure essential immunization even during the ongoing pandemic. Dr. Kumar was also instrumental in the introduction of 6 new vaccines and also in development of India's newborn action plan in 2014. Dr. Kumar is awarded with Scott Challenger Award, the highest civilian award by an independent organization for his contribution to the public health in India, and Southeast Asian Public Health Education Institutions Network Leadership Award for his contribution to public health in the WHO Southeast Asian region. So thank you so much, Dr. Kumar, for joining us this morning for this inaugural Immunization Summit. We are also privileged to have with us Professor Narendra Kumar Arora, Chair Global Expert Group Immunization WHO COVAX and President of AIMS Jharkhand and Patna. Professor Arora is a renowned global public health expert and is extremely involved in policy making, extensively involved in policy making, program planning, implementation, and evaluation of public health programs at the national and international levels. He has been involved as a principal investigator or co-investigator in over 60 major research projects funded by BST, ICMR, Government of India, AIMS, and international agencies like WHO, UNICEF, USAID, World Bank, and INCLIN. He has been the co-chair of WHO Strategic Advisory Group of Experts on Immunization, SAGE, and the chair of the 3 SAGE working groups. He is also former member of National Advisory Group on Immunization and Ministry of Health and Family Welfare, Government of India, and Southeast Asia Regional Immunization Technical Advisory Group. And Dr. Arora is a recipient of various prestigious awards and distinctions for academic excellence and research endeavors. So welcome, Dr. Arora, to this panel. We are also privileged to have with us Dr. Sanjeev Kumar, Chairperson of Indian Academy of Public Health and a member of Governing Board, National Institute of Health and Family Welfare, Ministry of Health and Family Welfare, and the former senior advisor to UNICEF India. Dr. Kumar has more than 44 years of experience in public health across 33 countries and worked with UNICEF for 22 years. As a Dean of Research and Training and Publication, he developed and facilitated courses for corporate sector, government official, and even NGOs in leadership and strategic management for India, Bangladesh, Afghanistan, Sri Lanka, and many other countries. As an executive director of National Health Systems Resource Center, he provided technical support to the Ministry of Health and Family Welfare, and he is currently Professor, Leadership, Global Health and Strategic Management at INCLIN Institute of Global Health, Chair of Indian Alliance of Patient Group, and also Indian Academy of Public Health, Chair for Institutional Ethics Committee of Gautam Buddha University, and member Governing Board of National Institute of Health and Family Welfare. So thank you so much, Professor Kumar. Professor Kumar is also part of our Apex Advisory Board. So we are privileged to have him on this session. We are also joined by Ms. Geeta Atreya, former communication specialist of UNICEF India. Ms. Atreya is a renowned public health specialist and philanthropist, and who has devoted her life to social development and human welfare. She has worked with UNICEF as program communication officer, handling all mass media and research activities related to polio program. And Ms. Atreya also worked with several bilateral and donor agencies, including Ford Foundation, Dutch Water Mission, and UNICEF. And she has a number of publications to her credit. And currently, as an independent development consultant, Ms. Atreya has helped bring about substantial global reforms while working with the government and local bodies in the domains of health and education. So thank you so much, all of you, on this panel and the beginning of India Immunization Summit. Let me begin today's discussion with Dr. Kumar. Dr. Kumar, I read out quite an extensive profile, and it's kind of summarizes the seminal work which you have been doing in the area of immunization, and I think especially for the health of the children. What has been the key learnings from these various missions, including some of the most remarkable ones like polio eradication and all? And how do you see that the same can be further scaled up so that the disparity is still there, and then the gap which we have not been able to fill can be filled adequately?
Thank you, Kamalji, and my co-panelists, very senior and eminent people you have today. Congratulations to you for organizing this particular session. So whatsoever, as I said, I'd like to start by saying that whatsoever I've learned, the field of immunization and child health, credit goes to, people and my, I would say, mentors like Dr. Aura or Dr. Sanjeev and other colleagues. Who have taught me, especially at the Ministry of Health when I joined way back in 2011. So, Kamal, I just want to cite one thing that, I always say that India is a story of numbers. And when I say story of numbers, means we look at the birth cohort, it's about 27 million right now. Look at pregnancy is close to 30 million. Look at our population is 1.3 billion. Anything you talk, you mentioned that we lose close to 1 million children, under 5 deaths in the country. It's still a very high number. But if you look at, the kind of progress this country has made, whether we're talking about maternal mortality ratio, which used to be close to 2,000 per 100,000 live births at the time of independence, it has now come down to 113. So it has been a tremendous progress. But still, we contribute highest to the maternal deaths, across the world. Similarly, we talk about under 5 mortality. Again, in 1990, our under 5 mortality used to be 126 per 1,000 live births. It has now come down to 34. Again, a tremendous achievement. But still, we are losing children. And when we lose children or mothers, let us say, because of preventable causes of death, I think that is where exactly is the problem. So when we talk about these missions that I've been associated with, especially, let us say, you mentioned the polio education program or maternal newborn tetanus elimination. Polio eradication program, WHO, the World Health Assembly, I think it was 41st, way back in 1988. WHO resolved that, yeah, we need to eradicate polio. So finally, it took close to, let us say, we started this journey of polio education program in 1995. I distinctly recall I was a young STM in Ranikhet subdivision. We started with the polio booths, and then finally, it took close to 18 years when India was declared polio free in March 2014. Similarly, when WHO, dissolved, especially in the World Health Assembly, it was 42nd in 1989. Eliminate maternal newborn tetanus across the world. So that was the time, but it took close to so many years. Finally, it was 2015 when I was in charge of this particular program, of Archie's program in the Ministry of Health. So again, it took close to, let us say, 18 years or 19 years when we finally succeeded. But ultimately, it was a long drawn process. And I started looking at the data. Frankly speaking, when we achieved these two monumental successes, polio education program in 2014, maternal newborn tetanus elimination 2015, I started looking at the data very closely. I said, look, we have eradicated polio, we have eliminated tetanus, but our full immunization coverage, I would say, was not very impressive. Because if you look at the full immunization coverage, in 2009, it used to be 61%. I'm quoting evaluated data. It increased to 65% in 2013. So 4 years and 4 percentage point increase, meaning thereby, if our birth cohort is, let us say, 27 million, so only 2/3 children were fully vaccinated. And 1/3, close to 9 million children were either partially vaccinated or they did not receive it, that is even a single shot. I dissected the data. Obviously, I had a very strong team and strong advisors like Dr. Aurora, Dr. Paul and all. We started looking at the data. I said, look, if the increase in full immunization coverage, the average is 1 percentage point per year, it will take us easily 25 years to achieve 90%. And do we have time for that? Can India wait for 25 more years to achieve 90%? I said, we need to have a different strategy. And this is how we started, looking at it. I further looked at the causes, and this subject is very close to my heart, and I talked for hours together. When I started looking at the data, what really stops people to take vaccines or the children? Why parents are hesitant? So you'll be surprised that a study which was conducted of the data which was collected by WHO on their monitoring process from 1 lakh parents of the children who did not receive vaccine. And to my surprise, 33% of the parents knew nothing about the vaccines. 30% of the parents only knew about the AFIs or side effects. So all put together, 63% of the parents either knew nothing or they only knew about the side effects, meaning thereby it was more of a communication gap. So thereby, when we started thinking about Mission Indradhanush, I think again a very innovative idea, which I was part of UNICEF. Professor Sanjeev mentioned about this. I used to work with UNICEF in 2001 and 3 for 2 years, and this was the state of Chhattisgarh, where Dr. Shukla, a very dynamic officer, he's a doctor and he was Secretary Health. So we sat together and we decided that let us have a new strategy for increasing the coverage. And this is how the 7 colors of rainbow, 7 vaccine preventable diseases. So I was looking for an opportunity that, okay, if we did it successfully, I was working on behalf of UNICEF. Dr. Shukla was in Chhattisgarh. So we implemented this strategy of mission in the 7 vaccine preventable diseases. So we're looking at this opportunity. Finally, when I joined Ministry of Health, so I said, okay, here's the time. I can really push this agenda of mission in the. So we started this particular journey, and frankly speaking, I'll just take one more minute before you go to our eminent panelists. So as I said, data is mostly about the communications. And when we started with Mission Indradhanush, we said it is going to be the health system strengthening. It is just not a campaign. It's going to be health system strengthening. And trust me, we put behavior change communication in the center stage of Mission Indradhanush. So we expanded the microplans of A&M. So again, this was one element of the health system strengthening. The second was the communications I mentioned. Third was monitoring, which was conducted by WHO, by UNICEF, all top-notch, let us say, experts. And the fourth was capacity building, the frontline works. The four, I would say, elements of health system strengthening were put together, and we started with this. So the 7 colors of rainbow, 7 vaccine preventable diseases. We started on 7th of April, which is World Health Day. So that added another 7. Then this campaign used to be for 7 days, starting from 7th of April to 14th of April. So another 7 was added. And you'll be surprised that when we got the evaluated data, another 7 was added, that the full immunization coverage, which used to be just 1 percentage point per year, it increased by 7 percentage points. So this is how, so we were able to increase the full immunization coverage, but because of COVID, now we are stuck, it has again come down. So I'll stop short here, come up for the time being, and I'll come at later sometime. Over to you.
Thank you so much, Dr. Kumar, for, reliving those experiences. And it is quite remarkable the way you use this power of 7, from the number of vaccines to the colors in the rainbow. And 2 important things which comes out of your, deliberation is that both things were critically or equally important, is strengthening of the healthcare system as well as the communication. And I think communication plays a very, very critical role in the, for anything which is preventive. And because for curative, people have a drive to go for a treatment, but something which is preventive, you don't know so the risk that has to be communicated to them adequately. However, I wanted to go to Dr. Sanjeev and Dr. Arora at this point of time, but I think we have the only women panelist in our panel. So for the I should have started with her actually, but let me take the communication piece first and go to her, and then come back to our other panelist, Ms. Satreya. So as Dr. Kumar was also highlighting that that 1 lakh data from WHO says 33% people were not aware of vaccine, and 33% people were only aware of the side effects. So the negative communication normally runs faster. Actually, I belong to a journalistic fraternity, and we were always trained that whatever is negative sells faster. And so we look for that information. And I think there are more takers for that. How do you deal with this whole thing, and what has been your experience? And because we did have some very, very, successful vaccination programs, especially I think polio. Which too had its share of hesitancy, its share of, I think, myths associated with that. What has been your experience, and how do you see communication playing an important role?
Oh, thank you, Kamal. Actually, in something like this, one doesn't even know where to start, because we have so much experience and there's such a lot of information available. But I just want to begin the story recently, recently to give an example. As I have already mentioned, in the USA, there is a huge backlash and there's a huge opposition to the COVID vaccine. And I was listening to a great interaction between the governor of a state and the people of that state, where the people are saying, we are Christians and we hear that this COVID vaccine is all made from aborted fetuses, no? From tissue from the aborted fetuses. And we will not be party to this. And you must respect the fact that we are all Christians and we will never agree to this. And we would rather, and they also said that if there is good management of COVID, if you did the correct things, you will not get into any kind of a bad situation as far as COVID is concerned. So instead of doing that, you're trying to push the vaccine on us. Now, this is from America, and this is 2021. So 40 years ago, in a country like India, when we started launching the Universal Child Immunization Campaign, can you imagine what our status would have been? Firstly, there was no service delivery at all. Secondly, people did not understand. I mean, the only tika they used to know was there are two kinds of tikas. One was about smallpox, which was done and finished. And one is about lagawing tika for, Bhai Dooj. No, that's about all. So this tika and tika karan was not really known. So we did a lot of work. So to get to cut a long story short, I think once we make sure that service is there, that service is going to be there, that service will actually be delivered, then we should really set about how to communicate. There are so many examples, but let me come back to the polio, because that is also pretty recent. In the polio campaign, that we had a lot of opposition from certain communities because very naturally they had all kinds of fears in their minds. And how we went about it is to do this massive social mobilization. The service was there. There were always all kinds of surveillance, institutions in place. On the delivery side, we were like pakka, and on the research side, we knew if there were any adverse effects or there were going to be any kind of wild polio viruses floating around. But on the communication side, we had to get across to people and tell them that this is really safe. Polio is a very particular example that because this is not a one-time event, this was going to be given again and again and again, and it is still being given again and again. So the communication had to be so thorough and the communication had to be so personalized. So we had this huge army of social mobilization workers. We had levels of social mobilization. They were all supervised very beautifully. And the message was delivered right up to the doorstep. And there was a personal touch added to it. And in my opinion, no matter how good the government programs are, in Government of India is the best government in the world because we have the best plans, we have the best plan of action, we know everything about everything, we know how to really, go about it, we have the good research backing. And I say this, let's say in the case of Anganwadis. No, we know the ICDS has been there in existence for so many years, but at the Anganwadi, at the last delivery point, we fail miserably. So the same is the case for any kind of a communication that we have to carry out. And we did this very well in the case of polio. My time probably has run out. We'll catch up again.
Thank you so much, Ms. Atreya, for this. Yes, important aspect has been a communication, and I'm sure we will get to hear more about it, and also in the case of COVID-19 also. So let me go to Dr. Arora now. Dr. Arora, with your this vast global exposure and experience, where you have seen a lot of successful immunization programs. You have seen diseases being eradicated. What is your take on India's immunization program so far? And what might have, there are a lot of successes to celebrate, but where we have also missed out on the opportunities. Professor Arora, you are on mute.
Yeah. Are you able to hear me now?
Yes, sir.
Yeah. So I feel really honored to be part of very distinguished panel, as well as participating in a subject which is very close to my day-to-day activities. So to me, the key issue which is transformative and which requires a sort of a whole of society approach is the keenness to preventive medicine, keenness to provide immunization to children, and keenness and understanding that immunization is part of development process at the highest level is, I think, is transformative. And this we have seen that in 78 or so, we started our universal immunization program. And what Rakesh ji said is actually telling, that 1/3 of the people who were not immunized were not even aware about immunization program. And another 1/3 were worried about adverse events. This both indicates that the aggressiveness with which the program is to be implemented, not just communication, but also providing delivery services and reaching out to everybody, has been something which we required right from the beginning. In 76, when smallpox was to be eradicated in 75, if I remember correctly, we had 500,000 cases of smallpox. And within 1 year, it was eradicated. We had last case in 1976. And so in 1 year, you can't create a huge infrastructure. You can't bring new human beings. But I think the keenness at the highest policy making transformed that. So within 1 year, we were able to do that miracle. Let me come to what Rakesh was mentioning, that when this understanding dawned that immunization is important, but we are moving at snail's pace, 1% per year, which is not anything. I mean, it can slide also 1%. So, and people like Dr. Rakesh Kumar were, when they were at the helm of the affairs, and I think they played a pivotal role in getting Secretary of Health and even the Minister of Health and maybe the Prime Minister. And programs like Mission Indradhanush clearly showed keenness at the highest level that we need to move forward. And as we understand, although you gave the example of NFHF 4 and then now 5, today I think at least one dose of any vaccine is almost available to 93 to 95% of eligible children, which is no mean gain. And we are touching 85 to 88% of fully immunized children at the moment in the country. Please leave the COVID period separately because there is a slip down there. Now, and this has come up again, system is strengthening. The PIRI strategy which Rakesh devised, periodic intensified routine immunization, Mission Indradhanush, has been appreciated the world over. and many other countries, because it was just not immunization. It was not a vertical program. It was associated with system strengthening, and it was not just system strengthening for immunization, because when you have a micro plan and list of every child, then you know whatever is to be given, whether it is vitamin A supplementation, whether it is their mothers to be taken care of, everything, because it is available. You knew them by name. There was almost like a registry of individuals were created. Next thing, that you mentioned even program, sorry to say that, you put it in a very simple manner. You did not give the importance it is due. I am sure all of us are aware that today's COVID program has been built on even. The backbone of the whole COVID program, which is now appreciated the world over, it is people like Rakesh Kumar has brought in that, and on top of that, now beneficiary listing has been done. We probably has the best registry of COVID immunized people. So I'm repeatedly saying that individuals are saying system strengthening has happened, more investment has happened. Program like National Rural Health Mission and then National Health Mission, they provided a paradigm shift in the management of the program. These were okay. But I think the key issue is that people at the highest level started thinking that immunization is important. I will end by just adding one last sentence. During last 1.5 years, 2,000 plus crore rupees have been invested on vaccine R&D. If it was not done, we would have been begging for the vaccine to the rest of the world. Today, you can buy a AK-47 or Rafale, but you cannot buy a single dose of COVID vaccine from the open market globally. Our people today have got 57 crore doses. It is because we are making it. Otherwise, you just can't imagine what would have been the status. I will stop at that.
Thank you so much, Professor Arora. And I think the ending was much more encouraging in that sense that what we did in last so many years, we are also reaping the benefits of that. Professor Kumar, I would put a rather mixed question to you, and then we will go to adult immunization. So we have been talking about the child immunization. So the next round, I'll try to have around adult immunization, and then the third round, I will go to the COVID-19 specifically. On this space, you have had there is a voice coming from the background. Himani, can you ask people to put on mute? Okay. So there have been you have been leading the immunization program for UNICEF in many countries. You have seen both sides of it. The system oriented or system related issues, as well as the policy making issues, and on the communication side, the uptake side of it. How do you see the Indian success story so far, and what are some of the good examples or best practices or experiences that can be leveraged to look into what has been left and can be addressed that as well?
Thank you, Kamal. One is congratulations to ISW for organizing the whole day event on promoting immunization, which is the most important public health intervention humanity has ever known. And thanks to eminent speakers and my old friend, Dr. Narendra Arora, whom I know from 71 when we joined AIMS. We just celebrated 50 years of joining AIMS about a week back. And Dr. Rakesh Kumar, we worked very closely when he was at helm of affairs in the ministry. And we used to meet, many times a week on that, and Geeta Treya, who taught me immunization. So I'll just take you through quick journey of I have been a program implementer for immunization, then later on moved to policy and other aspects. starting with 1978, we had a program called Expanded Program on Immunization led by WHO. But till 1985, the coverage was only about 5 to 15%. And that forced us to reflect. You always learn by reflecting on what we are doing. Why are we not getting the desired result? So came 1985 and the program revised and called Universal Immunization Program, and UNICEF became a major player globally in this program. And 1988, I joined UNICEF. Geeta was already in UNICEF. We looked at, we did not have strong infrastructure. We are fortunate today. We have cold chain. We have supply logistics well in place. India is a leader in vaccine production today. But that time, many vaccines, BCG, oral polio, etc., were imported. But how do you mobilize when you are strengthening the infrastructure is very important for us to know. The responsibility was turned over to grassroots level functionaries. Planning was not done in the ministry. Planning was not done at the state level. Planning was done at every PHC level. So we had what we called is micro planning. And these booklet, I don't know if you can see it. I still carry one copy with me. It was printed in a street corner printing press in Jaipur. Not a glossy book printed in Delhi with help from international agencies and sent to the states to follow. And this is in simple day-to-day English. Not even graphics. When you draw a map of sub-center, you mark every village. And all the households are marked on this. No fancy technology. Every ANM knew in and out. She took help from local people and marked every household. And the household which had a pregnant woman or a child was put across. This was the micro planning turned over, and we had micro planning training, not for district officials, not even for block PHC officer. We had training for every PHC doctor and every ANM and every male worker. Within 6 months, I remember my wife and daughter were ready to quit my home in Jaipur and come back to Delhi because I was traveling 3 weeks in a month. So that is the work. You turn it over to the people who are going to implement program. Micro planning is by them, not by state or central officials. Then you have to mobilize people. And Geeta will recall 20 questions or immunization. I still carry a copy with me. This was written in 2 hours, not by experts in Delhi. A group of people who I was just fresh from work at the primary health center in Haryana, and they asked me to prepare the first draft. Geeta will remember 22 questions which people frequently ask me when I vaccinated them. And then she edited it, and we had more than 3 million copies when I took the last count, distributed all over India. Who was responsible? We had a convention of the Sarpanches of Rajasthan. They were given a precursor of this, that you are the Sarpanch. We had a, Sarpanch of Rajasthan with a turban, with mustache. You are the Sarpanch. It is your responsibility to get every pregnant woman and child vaccinated. Then every ward punch was made responsible for getting children and women vaccinated in their area. We didn't have vehicles. We didn't have, forget about cold chain vehicle. We didn't have a Nehru Yuva Kendra volunteers came forward. Many of them had 2-wheelers. They will come to the PHC, collect the vaccine, go to the sub-center, give the vaccine to the ANM. And when I joined in Rajasthan in April 1989, coverage was between 15 to 20%. Within 20 months, December 1990, it reached 80% by mobilizing grassroots level functionaries. And that is how you implement program. That micro planning, I am very happy Dr. Rakesh Kumar is here, was revived in Mission Indradhanush. And the planning format was only 1 page. And it was developed with input from the grassroots level workers, not by experts sitting air-conditioned rooms of the Ministry of Health. They themselves planned that format, which was only one page, and it had all the list of social mobilizers, sarpanches, village priests, whichever community they belonged to. They were the ones identified, and each one of them was identified to be responsible for 10, 20 or 30 functionaries. So that's one good practice we need to revive and turn the planning not to experts sitting in All India Institute of Medical Sciences or ICMR or people sitting in Niti Aayog. Turn it to the people who are delivering the services. You will have a foolproof plan and you will be able to address hesitancy. Because they will know each and every one. You read messages from media or listen to TV, but you need somebody in your neighborhood, in your family, in your circle to tell, go and get vaccinated. Oh, your child is not vaccinated. Go and get your child vaccinated. You have any problem? I will help you. That is now you call it social and behavior change communication. No communication alone. Social and behavior change has to be part of it. Second is learning from child immunization. We have done very well. We need to now look at life course immunization. Kamal, you said you will come to that later.
Sure.
Third point I want to address is, how do you be prepared for the pandemic? We have a rich experience of looking at pandemics over a period of time. I was looking at pandemics human race has seen in last 2,500 years. We had the first pandemic in 430 BC of plague. But people used to travel on foot, on horses, on bullock carts. So it used to take tens of years for a pandemic to reach other country. When we had more recent times, 1918-1919 pandemic of Spanish flu, people used to travel by sea. So it came to India how? From the soldiers who were returning from First World War. They brought it to, and then it spread along the railway tracks. And then it went into the countryside. Now, within one day, you can go around the world and spread pandemic. So 5 of the 21 pandemics have happened in last 21 years. And we are going to face many more in future. So we need to be prepared and look at how it has behaved in past and learn from that experience that we can address pandemic. Fourth point, which I will say learn from Gita, community is the most important stakeholder. You are vaccinating them. You are preventing disease in them. They should be in the forefront. Think like a virus. Think like a common man on the street or in the village, how he or she gets infected and how the virus gets there. Act with them. They are the ones who are going to determine the failure or success of control program, failure or success of your immunization program. Otherwise, you will have fancy discussion on hesitancy and what can be done. Reach to the people through the people who are in their neighborhood, who are in their family, who are in their social circle. You will be able to address hesitancy. We'll come to other issues later, but to end, I will say, God helps those who help themselves. So it is responsibility of the community. You have to pass it on to them so that they take responsibility. Otherwise, you have a saying, "Aa bail mujhe maar." People will go out without mask. Vaccine is one protection, but you have to look at other preventive action. So you have to prevent infection by observing all the measures, which I will not repeat, along with vaccination. Vaccination is just one measure. Back to you, Kamal. Thank you.
Thank you so much, Professor Sanjeev. I think very, very interesting inputs you have shared. And definitely, as you said, that when we make society part of anything, achieving, I think even the most difficult targets can also be possible. We have done wonderful in the child immunization and infant immunization, and I think we have got great results also out of it. If I look at the glass, not half, but more than half full, almost 80% of the glass is full here, or 85% of the glass is full, as Dr. Arora also highlighted. And that's the almost, a full glass. So that's a wonderful achievement, which has been, kind of ensured with the people like Dr. Kumar and Dr. Arora and all of you. Now, when we have done this much, and in this age of higher NCD burden, where cancers, liver diseases, stroke, cardiac arrest, and all those things, cardiovascular problems, diabetes, all is there. There are still some diseases which can be prevented by vaccines. Especially if I can talk about cervical cancer or hepatitis B, or maybe liver diseases because of hepatitis, which is still having a lot of numbers. Dr. Kumar, how do you see the same zeal, the same passion towards saving lives, and the same intent towards bringing good to the society can be now utilized? And this is the high time of utilizing that, and especially when COVID-19 has also kind of highlighted that vaccination is equally important for the adults. Actually, COVID vaccine so far is for adults only. So, but at the same time, for all those at high risk, that influenza vaccine, pneumococcal vaccine for pneumonia and all that, there is a lot of, I think, preventive mediums available to the humanity, thanks to the research, to the of the medical science and the researchers who put their effort. Now, how we can actually make this reach to the people and rewrite some success story like what we did in child immunization?
Thank you, Kamal. Let me just, I want to just, because, I'm getting a bit nostalgic about this child immunization. I'll take 2 more minutes on this.
Sure.
So when Dr. Sanjeev mentioned about, the community participation, it's like the solutions lie, and better solutions lie where the problems. So, and I can tell you one thing in my experience, because I've been district magistrate in 7 to 8 years. I've been in the field, and vaccination has taught me a lot. The best solutions, they lie, with the people. They'll tell you what exactly is the where exactly. So, and they can't be really formulated, sitting in the ministries and all. So when we were devising and we are working on the communication strategy for mission environment, interpersonal communication plays a very important role. And without, agree to what I'm saying. So I spoke to my chief minister, Natasha was my minister. I said, sir, is it possible we will draft a letter, and if you can just write a letter, complimenting our frontline workers, whether they are ANMs or ASHA workers or Anganwadi workers. So I got a letter signed for the frontline workers by the minister. And trust me, when it went across to everyone, ANM, ASHA workers and Anganwadi workers and whosoever was there, staff nurses, they were so elated. So interpersonal communication becomes very, very important. The second point about the social mobilization network, why I became nostalgic, because I was working with UNICEF in 2001 in Bhopal, of course, but working for the state of Chhattisgarh. When there was a polio upsurge in 2002 in UP, and UP, harbored more than 65% of global polio cases. If there were 1,600 polio cases in the world, 1,200 were there in UP alone. And the resistance was so high, as Geeta mentioned about this. I took the chief of health, of UNICEF to one of the villages in Barabanki when in 2002. He visited, and I was basically sent on a mission from Bhopal to Lucknow because cases were so high. And I established, this social mobilization network, this army of close to 3,500 people at different levels, village level, community level, at all the levels. So I took my, the chief of health to one of the villages, and you'll be surprised, we visited a family. I asked that, whether the child has been immunized or not. And you'll be surprised that the father who was holding the baby, he threw the baby on the floor. Just he threw. And we were so, he said, जो आपको करना हो करिए. मैं नहीं चाहता हूँ अगर आप मुझको पिलाना चाहते हो तो आप पिलाइए, but I don't. So that was the kind of resistance. So I think the social mobilization network really played an important role in mitigating the vaccine refusal or hesitancy. Just two more points before I go to this. We were talking about this electronic vaccine intelligence network. When I started looking at the data, so there were threefold challenges. One was the coverage, so Ms. Vindadhanush was able to take care of them. The second was expanding the basket of vaccines because we were just having 6-7 vaccines only. But how to expand, so there's 5 or 6 new vaccines were introduced. Whether we talk about IPV, we talk about Rota, PCV, we are talking about MR and all, and other J's. These 5 new vaccines were also introduced, and pentavalent was getting expanded. Professor Rhoda is a pioneer, so he started, this particular work in 2 states of Karnataka and Kerala, pentavalent, in 2011. And finally, they were expanded to all the states by March 2015. UP was the last state. So we're just pushing this pentavalent agenda also. But I think important point was that, so this was taken care. We expanded the basket of vaccine. But the third important point was the electronic vaccine intelligence network, and that was the quality. Basically, we're looking at 2 things. One was the supply chain, because close to 8 to 9% of sessions were not being conducted because the supplies were not available. So this simple Android technology through electronic vaccine intelligence network was introduced. So one was to ensure that the vaccines are available, and second was maintenance of the cold chain, because even if, let us say, you improve the coverage by 80%, 90%, and the quality of vaccine is not taken care of, if the temperatures are not maintained between 2 to 8 degrees, because of the breakdown in electricity in remote areas, like you mentioned about Hamirpur, your place. I've been district magistrate in Mohga, so I know that particular place. If suppose, let us say, the electricity is not there, and still you are inoculating children, and the quality is not good, so there's no point. So the second component of electronic vaccine network was basically, maintaining the right kind of temperature. So we inserted these loggers, temperature loggers, in cold chain, equipments. And we started this in Shahjahanpur and Bareilly. So these 2 districts we piloted, it was so very successful, and it went across the globe. The last point was, when we talk about mission Vindadhanush, I always say, we started with, let us say, polio eradication. We did smallpox in 1976. We did, eradicated polio, maternal newborn tetanus illness. It was mostly the health system strengthening. It was not a campaign, but health system strengthening. What I say here is that we expanded polio eradication to full immunization coverage, MI. Why can't we, let us say, why can't we make it a mission in the Dhanush Plus? When we say it's not only because it's the basket of services, we are reaching out to a particular family. And suppose we are just going with the vaccines. We say, no, the parents say, no, we don't want vaccine. Vaccine is taken care of. What? So, it's like from polio to routine immunization to larger public health agenda, frankly speaking. And I like to go one step further, say that why can't we go beyond the public health sector intervention? Because social determinants of health, they play a critical role. If you are achieving health, 50% achievement comes beyond the health sector interventions. My gurus like Professor Sanjeev Kumar and Dr. Arora will agree to me what I'm saying. The fact is that 50% of health comes from non-health sector interventions. So when we are going for the basket of vaccine, for the basket of services, from polio to vaccines to public health sector and beyond health sector interventions, I think this is the approach which we need to, The last point on adult vaccination, Dr. Sanjeev will talk more about this. But now, because, we started adult J vaccine, so that was the first kind of introduction. We have TT coverage for pregnant mothers, 2 shots are being given. But yes, this is high time that we need to look after the adult population. And COVID has given us tremendous experience of dealing with adult population. I had a close interaction with Asian Influenza Society. Very senior people are there, they're part of this. And they are trying to promote adult vaccine, whether you're talking about pneumococcal vaccine, you're talking about influenza, or hepatitis B, or any other vaccines. I think it's high time for the country that while we sustain the child immunization, we need to move and look after the adult population. And you mentioned non-communicable diseases. If you have the communicable diseases which are preventable through vaccine, then obviously we can understand what can be there. So I think I'll stop short here, Kamal, for the time being. I'll come to you again. Over to you. Thank you. Yeah.
Yeah, I was on mute. So thank you so much, Dr. Kumar. Dr. Arora, let me come to you now. And, what I heard so far is that there seems to be a incredible system available in terms of ensuring that the vaccine reaches to uh, which is 80-90% of the children we are reaching, and we are reaching so meticulously, I believe. And as Dr. Kumar also highlighted, that when we have this system which can deliver a whole kind of bouquet of health services, what how can we leverage the same? I think, see, for example, I mentioned about cervical cancer, which was number one cancer. Now it has been kind of taken over by breast cancer occurrences in our country. But this is something which is preventable, and we could give that HPV vaccine to all adolescent girls. This health system is reaching to the doorstep. And I think by just adding one more this, we can achieve that outcome also, which is, I think, equally important. What is your opinion in terms of what should be the way forward in, for having a more uniform, robust, and I think purpose-driven, or maybe as passionate as for children, a vaccination program for adults as well?
Yeah. Kamal, is the question to me, directed to me?
Yes, sir. Yes, sir.
Yeah. So there are a couple of things when we talk about vaccination beyond children. And so whether it is HPV vaccine, whether it is hepatitis B vaccine you are talking about, and now we are talking about COVID vaccination for all age groups, across the age groups. So I'm sure Rakesh remembers distinctly, because one of these Saturdays or Sundays we convened a meeting on adolescent health. And so we have been talking about adolescent health, but we need to have a platform where we function for adolescents. Just like for children, immunization, first 2 years is like a platform where all kind of pediatric services are provided. Similarly, for adolescents, it is not just go ahead and pick people it straight away from a program perspective, and even scientifically, community-wise, people have to be kind of understood how the whole institutional arrangement in a life cycle approach takes place. So if we have to really give HPV vaccine to all our adolescent girls and later sometime boys also, a platform where bouquet of services is to be provided. And that may be, so school may be one option, but are there other options? One need to keep thinking. And similarly, like one we have the Well Baby Clinic for children below 1 year. Now these Well Baby clinics are expanded to up to 2 years. Similarly, I think wellness clinics are required for adolescents, let's say. I think adolescent is very important because it is the foundation for the rest of the period. So whether it is chronic disease, whether it is infectious disease, whether it is lifestyle, whether it is substance abuse, everything is critical at this time. And in addition, psychosocial stress, mental and emotional issues arising at this point. So a platform with a bouquet of service, and it takes some time for a system to come up with that. So although Ladli program and some of the programs have been announced and are in practice, but I think it has to be sustained and pursued so that once the platform is formed, then it can be taken up. The adult immunization, which we talk at this time, is, I think, probably a lot of it is huge communication which is going around us 24/7. And that pandemic and fear and the associated
loss of lives and the system kind of a disruption which has taken place, I think has done a lot of good as far as adult immunization for COVID is concerned. That's why we are seeing such, I mean, to immunize almost 46 crore individuals in this country is not a, I'm now talking about individuals, not the doses. 46 crore individuals coming and having at least one dose is not a joke, but it has come up because of the massive kind of barrage of information which has occurred. But I think a platform tomorrow, if I just want to give influenza vaccine to older than 60 years, how do I do it? So Ministry of Health this time came up with a innovation called near home COVID vaccination centers. So for clusters of 3 or 4 villages, a immunization center has been set up where people above 60 years and those who have fragility, who fulfill the definition of fragility, come over. So I think this has to be taken up in a systematic manner, and as I said, use the word whole of society approach is required. We need program system, program issues, delivery system. We have to have a social mobilization component, community engagement component, and also to see that while we talk of adverse events only for vaccination, that may, because these are too visible, but I think for all other programs, a community feedback mechanism is also required, because vaccine safety is something which is like a feedback about the vaccine. I think a similar system for other programs may also be required at some time in our broader framework. I'll stop at that.
Thank you, Dr. Arora. I think, yes, so what you are highlighting, that the way we have taken child immunization in a so institutionalized manner, where a platform and I think focus approach was created, the same need to be done for adolescent and as well as adult vaccination as well. For that, I think also what has to come is that the institutional will and political will also. So let me go to Dr. Sanjeev Kumar on that. Dr. Sanjeev, how do you see that? Do we see that some kind of adult and adolescent vaccination policy emerging or a program emerging from the government? The society has a great role to play. The health system which has been built over the time has a critical role to play in that. But I think the beginning has to start from the government, which is right now I think is absent, and then we are losing a substantial number of people every year. I quoted 40,000 Indians are kind of dying because of pneumonia and other infectious problem, I think, which can be taken care of by pneumococcal or influenza vaccines among adults. And I think that also is important from the COVID-19 vaccination point of view, because what we are looking at COVID-19 vaccination, that okay, once you get, and I think that's a big communication roadblock also, that people feel that getting vaccine means you will not get disease at all. I think, and even 80-90% of efficacy is also being conveyed, that there is a 10% of inefficiency or inefficacy as well. While I think those influenza vaccines have hardly 60, 65 or maybe that range of efficacy. So I think we are not attuned to getting a vaccine or a regular vaccine, and we are, I think, staring at a situation where maybe COVID vaccination also become an annual routine. Or maybe biannual routine. So what is your opinion? Do we see that this is going to trigger into some kind of a more universal program for adult and adolescents? Sir, you are on mute.
Thanks, Kamal. We have a policy for elderly population in India. It lists some of the possible vaccines which can be given. Those of us who know and those who live public health, there are many people who know but don't live. I got pneumococcal vaccine. I got meningococcal vaccine. I got a booster for DPT, and I take flu vaccine every year. And I've been taking flu vaccine every year for last 18 years. So yes, government may provide, but those of us who are so-called educated should at least come forward and get vaccination done. The market will expand, and when the government tries to procure these vaccines, the cost will have already come down. COVID has opened the door and has probably given the confidence to the policymakers that yes, we can vaccinate, and what is included in the policy can be taken to practice for elderly population. I am an immunization person. I always say, even if one dose is missed, today, if you have to import vaccine, because you don't know which vaccine is going to save life and which life. So every vaccine dose is very important for saving life. So if you are running short of vaccine, import vaccine. Wherever you get vaccine, get it into the country and vaccinate people. If you have your capacity, you increase your capacity, but don't delay vaccination of the people. We have more capacity to vaccinate than the vaccine available today. So that is one aspect which needs to be done. In India and rest of the world, what we as public health experts get frustrated is, we are not looking at when am I going to vaccinate the last person. We started immunization program, EPI, and then 78 and UIP in 1985. And even today, the last child is not vaccinated. Who is accountable? We have to fix accountability. It is not at grassroots level. It is somewhere at higher level. We need to reach out to the last person and put all our might into scaling up interventions. Immunization is one, but there are many other interventions we have not looked at. When are we going to reach the last beneficiary? Immunization program, 35, 40 years, we have not reached the last beneficiary. And thanks to some of the people on this panel and outside who have put their influence in scaling up immunization coverage. So that's one. And many of these diseases are silent killers. Elderly person dying in the hospital because of infection will not make the news. But when you look at the data for the whole country, the number is substantial. We need to have some sense of urgency that what vaccine is available in the country, promote it through private channel, fine. Those who can afford will at least get vaccinated, but that bring it into the routine immunization program. We are struggling. We never met the target of 2% GDP expenditure which we laid in 2002 policy. We have not met the target, at least still now, of 2017 2.5% GDP. This is the most cost-effective intervention. Put the money there. And there are people who are eligible who need to be vaccinated. You have put the infrastructure in place. So my message is their sense of urgency to the policymakers and to the program managers to roll out these programs which are for adolescents and for the adult population. Bring in some sense of urgency, but never forget the second part of your question. None of the vaccine is 100% protective. Only vaccine which is near 100% is tetanus toxoid, provided you have taken 5 doses. That is close to 100%. After taking 5 doses, respecting the interval, there has been no tetanus death reported in the world. And I worked in the army. Nobody died of tetanus in the army in Second World War and after the Second World War, because they are all vaccinated. But none of the other vaccine is 100%. But don't wait for a vaccine with 100% efficacy. Take whatever is available. Protect yourself from infection. Yes, get vaccinated. Work, regular exercise, dietary intake. We will not go into details what kind of diet, which boosts your innate immunity, the general immunity. And the last message is desirable practices when you get infected, because it is only infected person who spreads infection, no one else does. So these are the measures along with vaccine, which is not 100% effective. You have to continue to promote. Thank you, Kamal, back to you.
Thank you so much, Professor Kumar. Let me go to Dr. Himani. Could you please see that there is a background sound coming? Can you put others on mute? Thank you. So let me go to Geeta ji, and you have mentioned two important things. And now, I would try to look beyond the responsibility of the government. And as you said, that as a person, as a public health practitioner, you have been regularly getting immunized for whatever vaccines are available for adults. And I heard a couple of times that you getting your daughters also immunized for HPV vaccines at the time when it was, due. Geeta ji, I think we have a lot of people who can definitely afford to go for vaccination, and they need not to necessarily wait for government to come and vaccinate to them. And we have seen this in the COVID-19 vaccination also, that where the uptake, especially in urban areas, is substantial from the free vaccine programs. People are going to the hospitals, private hospitals, and paying for it and getting that vaccine, and they are even ready to buy even expensive vaccine as well, because there is a very high level of awareness because of COVID-19 and its scare. How we can leverage the same kind of communication and conviction among the people, so that they also start going for these other vaccinations which they can opt for, and the government has a policy which has listed a certain vaccines which can be beneficial for, let's say, especially for elderly population. How we can leverage the power of communication for that, that people at least start taking the vaccinations as much as, or at least those who can afford it. Geeta ji, you are on mute. Sorry.
Thank you. There's been such a lot said, and such interesting things are being said. I mean, we can really learn such a lot, and we can really discuss this for a long time. I think as far as adult vaccinations are concerned, for example, HPV, this can easily be done even through the school system, because we want to catch all kinds of adolescent girls. And the school system is a very good way. We can pass on information to the parents, first to the schools, and then the schools can monitor. And this is also good for anemia control. Now, if you want to give iron and folic acid tablets to the adolescent girls, this is a very good way. So the entire school system, if you're reaching adolescents, we can do it through the school systems. The school doesn't have to give the vaccine. The school just has to pass on the information, convince the parents, address any kinds of fears and problems that they may have. People may have all kinds of beliefs also. We have to tackle them. I think one of the important things is that I have learned is that people's fears have to be addressed. If people are scared for one reason or the other, we cannot just brush it aside. No, we have to address that particular fear. For example, to talk of vaccinations and giving our children vaccinations, I used to be in England when my children were born. My twins were born there. And there was a huge outcry at that time about the pertussis vaccine, that the vaccine itself was causing all kinds of, mental problems and stuff like that, and some kind of, problems in children where they become, completely, useless after that. So I did not give, after one dose of the pertussis, I did not give the other two, because the media information on it was so strong. So I gave DT, but I did not give DPT. So it happens even amongst educated people, the fears that people have. So as far as, adolescent programs are concerned, we can reach. Then we bring out a 20 questions booklet, address each vaccine separately, and we address the fears of people, inform everybody, take any kind of a feedback that comes in, look at adverse effects, after vaccination and address them, because no vaccine is completely foolproof, as we all know. As far as other adults are concerned, seniors are concerned, for example, again, I think partly it is the question of reaching, elderly people. How do you really reach? Some elderly people in the better of classes can reach themselves to hospitals or to places where vaccination is being given. The middle class, I think they can go and they can also afford, but then there's a range. There is a range in the for example, in the COVID vaccination charges. I paid 250 rupees. Now it is like 750 rupees or 700 rupees or 500 rupees. This range is very confusing. And so I got both my vaccinations for 250 rupees each but now it's become 500 rupees and some places it is 550. So there is a lot of, confusion on exact charges that people have to pay. So let's address that question. If some questions like that come up for affordable vaccines, people can who really afford. Then there are a group of people, for example, in COVID vaccines or other, vaccines like, influenza or pneumococcal. People just don't know. People don't know. And also, there should be, again, a range of prices available there also. No? I may pay 1,100 rupees for an influenza vaccine or 1,400 for a pneumococcal or something like that. But that cannot be even for the middle class. They may not be able to afford. So again, the pricing there has to be looked into. Things like that have to be looked into. And again, information, beliefs, false information, addressing the fears. We have to carry on with all of, you have to work on each one of these things separately. There's a lot of work to be done, in developing packages for each one of these things. For example, during immunization, Sanjeev would remember, we not only brought out 20 questions booklet, we brought out something like the checklist for ANMs and health workers, the 100 questions, the 100 things that they will have to do. The 100 thing checklist, Sanjeev. So even health providers are not very sure about when it comes to all these other kinds of vaccines. So we have to have information packages developed. If my time is running out, I'll be happy to stop here.
Thank you so much, Geeta ji. And communication is important. But at the same time, what you have highlighted, that I think the affordability of the vaccines, which we want to actually make more people go for, also need to be regularized or maybe kind of rationalized. Let me just take a very small, because 12:30 is the next session and we have got all the speakers there, but two very small interventions about COVID. I think Dr. Sanjeev has covered about COVID as well. So let me go to Dr. Rakesh Kumar. And Dr. Rakesh Kumar, Dr. Arora also highlighted, and yes, COVID, which is something, one of the finest technology backbone which was created for the country like of our size. And I think it has done a wonderful work with almost 56.7 crore doses has been administered, I think, so far, which is a massive number when we talk, count about the doses, and around 12.5 crore fully vaccinated people. Percentage wise, we are just at 9.2% in the fully immunized, thing, which is obviously, as Dr. Geeta, so Ms. Geeta also said, that is a lot need to be still done. And I think this is something which is need to be done, building the ship while sailing and amid the storm as well, because everything is kind of so fragile and dynamic, keeping in mind that we are in the middle of the pandemic. Since you were part of creating that such a robust technology, even which now with certain customization is helping as a co-win also, what is your take on the India's COVID-19 vaccination so far, and what are your suggestions that how we can actually reach to the level of 60-65% of vaccination quickly?
An excellent point. I think, Kamal, if I may say, then COVID has been the most, I would say, successful instruments in even accelerating our COVID vaccination program. You look at the hesitancy, rather when the new vaccines were, for the COVID vaccines were made available, I was thinking there will be a lot of eagerness. There could be a different situation, not the hesitancy. I was not looking at hesitancy. I was thinking that there could be more eagerness. There could be, righteous situation in the society. People might be just running because there was shortage of vaccine. But hesitancy has really, obviously, that's a factor. Two things important. Technology, as I said, on the lines of even electronic vaccine transmission, COVID has been developed. And obviously, this is the most robust system which is available across the world right now. But I said communication becomes very important. And communications have to be simple, straight. There can't be multiple sources of communication, and especially in COVID and COVID vaccination. Coming right from the Prime Minister's office, from Honorable Prime Minister, you would be looking at one thing, that you are communicating just a limited set of people. It's not coming from so many people. So I think two important factors, that we do right communications. Obviously, vaccine availability becomes important, but as a technology, communications, availability, how best we can fastest, like another innovative solution which is being provided, that the vaccines are available right next door. You can go anywhere, it's freely available. Anybody can go. Now, more than 18 years, people are getting, initially we said more than 60 years, then 45 to 60 years with comorbidity, and now it is open. So I think once, I don't see any reason that India is not able to achieve or ramp up its COVID vaccination program in due course. We are now at number one in terms of, looking at the number of people who will be vaccinated. Maybe we are close to 10% who will receive 10%, but in due course, I think next couple of months, we are going to increase it further. I'll stop short.
Thank you so much, Dr. Kumar. And communication and I think availability of the vaccine is also important thing. We have a system, we have the robustness of the system that is going to, I think, be a backbone of it. Dr. Arora, since you mentioned about that it is possible to buy a Rafale at this point of time, but not a vaccine. And keeping in mind your global exposure at COVAX, and also the kind of vaccine access disparity we are seeing, how do you see India's fight against COVID-19 so far, especially from the vaccination point of view? What need to be, if there is any need of course correction, what can be that? Dr. Arora, quick remark.
Yeah. So,
sir, your video is off.
Yeah, I hope it comes, or otherwise I'll continue.
All right. Okay, continue, sir. Then. Okay.
Yeah. So, in fact, I'm chair of the COVAX facility at WHO also. And the overall situation is that there is only limited supply of vaccine available. And therefore, to say that we could have, what additional could have been done to achieve 65%, or we purchase the vaccine from anywhere and give it to our people. So I must share here that there has been a lot of effort to get additional vaccine doses from across the globe. And you must have heard in between that Moderna vaccine, 7.5 million doses are going to come to this country. But the fact was that there is strings attached to this offer, what is called indemnity and liability. Dr. Rakesh Kumar would understand carefully that this is something which we would never accept, because we are the largest vaccine producers. And that is what happened, that India refused for those. And the amount of dose was not sufficient even for Saket in that matter, if I can use Delhi example. The amount was minuscule. So at the moment, the way things are, whatever vaccine will be available, it is being given. It is like, as you very rightly said, we keep on kind of making the ship as we are moving. And we have seen in between there have been days when 8 or 9 million doses were given. Actually, all of us who are involved with the immunization program, we know that India immunizes 170 million children in 1 week as part of polio program. And our coverage is 98 to 99%. Therefore, one can understand the capacity. The whole infrastructure is available. The question is, as the COVID vaccine production is ramped up, availability is increased, I think we should be able to meet. And that is why we are expecting that in September we should have 20 crore doses. In October, we should have around 25 crore doses. And in December and November, about 35 crore doses every month. And they would be all delivered. So that the whole objective is by the end of the year, we are able to give the vaccine to most of the eligible adults. At this time, another narrative is coming up, and that confuses. Actually, the cost and the other private sector's role has been minimal because they have not been allowed a free hand to make profit. So I'm being a little bit, I think, probably not in the correct language, but the fact is that's why they are contributing only 6-7% of all the doses administered. But the other narrative which is coming up is children, immunize our children early. The question is, below 18 years, we are 44 crore children. Where is the vaccine? And children do not suffer from serious disease. And adults, means there will be a situation कि माँ बाप मर जाएंगे और बच्चे को vaccine लग जाएगा, यतीम हो जाएंगे. So parents have to be given the vaccine first and then the children, because children have very mild disease or asymptomatic disease. So I think the issue of prioritization and the way deliveries are done. The second is, you made a point that urban phenomena. Sir, today the total vaccine, if you visit COVID dashboard platform, 2/3 of the vaccines doses are delivered in rural areas. And the uptake in rural areas is very good. In fact, toward the end, I will make a comment that vaccine acceptance is among the highest in Indians. Vaccine resistance and hesitancy, even globally, when we look at the data, is one of the least in India. I think we Indians, because we say prevention is better than cure, is very much ingrained into our system. And as a result, hesitancy is not such a big problem as we see in some of the high-income countries. I will stop at that.
Thank you so much, Dr. Arora, and quite a positive ending of this session, that we as a country have the highest acceptance of vaccine and the lowest hesitancy. I think that's the best way to look at when we are kind of hoping for the kind universal kind of vaccination of our population amid this COVID-19 pandemic. I will stop here, and we had a wonderful session, and one thing which I think is a takeaway is that India has done remarkable stride. I think one of the most incredible journey we have traveled in the last 70-75 years, while seeing our population adding by almost over 1 billion in this period, and we have been able to save so many lives. There are certain gaps which can be definitely filled. We have that a strong health system with us. So the next session is going to dwell more upon it, and we have our host, Dr. Hema Devakar, CEO of Artist for Her and former Foxy president, also the member of our Apex Advisory Board, to discuss more about the child immunization and how we can actually continue building a healthier country, and also ensure that the vaccines reaches to all those children who are still out of this safety net. Thank you so much, all our panelists today, for this wonderful, insightful session. And over to you, Dr. Devakar.
Namaskar. Thank you, Kamalji, and the brilliant set of panelists who have given us a first dose of infusion of enthusiasm and our resolve, or the shapath, to do more and to do better continues onward in our vaccination saga in this particular fine morning, where being in the women's healthcare space, I have been rightly asked to address issues around the pregnant women, which comes in the category of a niche adult segment. And of course, if she's pregnant, someday she has to deliver. And then there is a newborn, there's an infant, there's a child, then grows into adolescent. So the vaccine story begins and continues forever and ever after. So we have today with us a set of three very distinguished panel members. It's my proud privilege to invite Dr. Dinesh Baswal, the evergreen, ever willing, ever supporting champion who has been a guide, a mentor, and he is the Deputy Director of the programs at Mamta, and he has been the ex-Joint Commissioner, Maternal Health and Family Welfare from Government of India. Namaste, sir. And I think he had already sent the call that he is in a traffic jam and he will join us soon. So thank you for being with us, because we are all in a kind of a jam with the COVID pandemic itself surrounding us. So welcome, sir. The next panelist whom I would wish to very fondly welcome after many, many long years of association, we are meeting again, Dr. Sumarendranath Bagchi, who is the lead immunization implementation program, Clinton Health Accesses Initiatives. I must say that the gap between knowing what to do and actually doing what is to be done, that is the key piece of implementation, for which a lot of pride and credit we give to Dr. Bagchi, who is here with us to share his insights. Last but not the least, my very beloved Ms. Shaimashri Das, the icon of youth, if I may call her, the voice of the youth, as in the Gramavani program that she is associated with, and the power of youth, which is so well recognized by Shama as the program manager and the focal person for youth in the Empower in Social Action. That is a very strong segment on whom we bank to encash and do more. Shama is the program officer, vaccine delivery and infectious diseases at the India country office with the Bill and Melinda Gates Foundation. So namaste yet again and welcome to my very beloved panelists. The topic is challenges, opportunities and impact. Well, what is a life without challenge? So we are all here to find an opportunity in that challenge to do more and to do better and to do very differently, to use that opportunity to make this world a better place by creating the impact of the actions that we hold ourselves responsible for. So this is a very positive tone in which we are going to be running this panel, because we know that a lot more needs to be done, but we have to begin somewhere, and we have taken the resolve or the shapath to begin right here and now to what is the best input that we can draw from the experts in our panel, so that we imbibe the spirit and be inspired to do our bit to make a difference in the vaccination story in our huge and a complex country. The previous panel very intensely discussed the communications. They said at the start of the polio program, the reason why the polio vaccine was not being taken is because 30% of the parents didn't even know that there is a polio vaccine. Another 30% had heard only about the side effects, so they were scared. So a small segment was there without hesitancy, approachable. So awareness and communication seem to be the foundation of reaching where we want to reach. So let me begin with Dineshji first. Communication, sir, then and now, in your expertise being on the government front, what has been the difference and what has been the uptake of the communicative methodologies to generate the demand. So
So actually, this basically communication is the key, especially in these programs, and especially immunization program. I think communication is the key. Of course, the standard the standards basically like interpersonal communication. These things are there, but now I think and also the print media and other things, mass media is being used. But now there is a shift from that to the more social media,
yes,
and being used. That platform is being used more now, and basically, like Twitter, like Facebook, like the Instagram. So these are the new platforms which is now being used very effectively. And WhatsApp is another one which is being used, and there is a lot of I think opportunity there. We can form groups and pass on the message which we want to pass, which reaches the community very fast. So I think the social media in itself is a big area where we can and there is a huge shift from the government, and government also in spending money on, because when any ad comes into the paper, it is hardly seen by very number of people. But when you make a group and there is a constant interaction with that group, so they are actually basically the WhatsApp group, for example, has a lot of potential which can be used.
So there's a small follow-up question I want to place, because oftentimes when we discuss the National Digital Health Mission and the digital mode to reach people, they say, oh, you're in the metros, the hi-fi, you're talking, but there are women out there who don't possess their mobile phones, they have to lean on their support of their husbands to lend them the phone, for example, or they're not empowered at all. Internet connectivity is not there. You're thinking you're reaching, but you're not reaching. And is this true, or are we getting better as the days go by?
No, I think we are getting better. When this Geo launched this connectivity and giving a lot of GB space to people in I think that's one of the cheapest in the world. They claim that, and given that sort of a bandwidth. And there are a lot of people which are innovating now, in local languages, different language, regional languages also. And it's not necessary that communicate only in, and also the material can also be basically customized to our population. Right. So there is absolutely a huge amount of scope or opportunity which is there, and we can actually tap it.
Excellent.
And with the mobiles being, reaching everywhere now.
So, everything doesn't happen overnight. So we are reaching there. So we will soon put this at the back when people say that, no, there is this. So the percentage of reach, slowly but steadily, it is percolating deep down into the pockets where we mean to reach, where we can't probably reach physically or by any other means that you can think of at this day and age, but there is an ample scope and opportunity. Let me swing back to Dr. Bakshi. I want to take the same point across to see more challenges with this communication system in the social media and digital world, the Google and the WhatsApp universities and the fake news, and how do you think that you perceive this as a real challenge, and what efforts are we making as responsible people for giving authentic information, which often, probably is not communicated in the right way because the technical jargons which are not appealing or acceptable or understandable by people. So it is just that we've shot some messages, but nobody out there gets it. But the gossip around the WhatsApp university, like for example, when you're having your menses, do not take the COVID vaccine. That was one of the big, news in the social media circle. So what is your take on this, sir, and what could be the approach to make this as correct as possible?
Okay, thank you, Dr. Hima. and also thank you, Dr. Aswal, as well as Dr. Sama. See that if you ask me, before COVID-19 vaccination, the immunization communications through the social media, WhatsApp and everything, it was almost nil. In fact, nobody knew about the children vaccination. Although in India, if you see the vaccination of India, we have 27 millions of the infants every year born who have to be vaccinated, and 29 millions to 30 millions of the pregnant women every year they have been vaccinated. So it is a very huge scale, in fact, in that way. But it was never become surfaced into that thing, because that's why it is called a routine immunization. But COVID-19 actually changes everything. So we have to discuss on the backdrop of the COVID-19. Yes, COVID-19 creates a opportunity for interest of the vaccines to the common people, right from the very poor society strata to the very high society. That is one. It also creates a lot of challenges about these vaccines. As you mentioned, that the WhatsApp university is there, Facebook university is there, Google's university is already there. So that really creates a challenge. Challenge means why? Why there is a challenge? Why people are forwarding the message continuously on WhatsApp without verifying the facts? It is because it is very easy to communicate. It is very attractive for the community members. In fact, in my family also, I have seen that it has been forwarded. One of the reasons is that the correct information regarding the vaccine's efficacy, dose, all these aspects which we are seeing in COVID-19, that has been circulated by the government. I know that the government is giving a lot of information there, but due to this community, it is not reaching to the community in that way. That is one of the challenges are there. So what I'll suggest is that and that creates a lot of problem. In fact, why I should take a vaccine. I know that some people have taken vaccines and they died, like that. All this misinformation. So that is one of the very important points by the governments, by the NGOs, by the responsible community members to stop that thing. But there is a positive side also there. We are talking about the children vaccination. You know that in the children vaccination, in spite of these best efforts, there are two very important identification which has come from the concurrent monitoring by the partners, is that the 28% of the population of India, there is an awareness gap about the vaccines. 28%, mind you, the Indian population, and if you see the 27 millions of the infants, if you subtract it to the 28 to 30%, it's very high.
Yes.
So that can be very well, the government should, and the NGO, everybody should use that thing, using this communication material. That is one.
Yeah.
Another very important thing which actually prevent the 100% vaccination or maybe 90% vaccination is a fear of AFI. AFI means it is a fear of the side effects.
Adverse effects, yeah.
We can talk this thing. So that can be very well, and especially for some vaccines which gives a fever. And it gives a fever. If you see the poor community, the poor strata of the society, they are actually daily wages. So if they stay back in the home for their children, of their infants treatment and pay out of pockets, definitely it will affect their interest in the vaccine, and that comes to 34%. So these two amounts to 60%. So that 60% can be very well tackled by using the different communication channels. What we know that WhatsApp, Facebook, and there. And also there should be very aggressive communication strategy should be taken by the local self-governments and the NGOs regarding the importance of vaccines. I will just speak another few minutes is that,
Please,
because we work on polio right from the day one. I was working in WHO in 2001 and 2. I have seen what are the community resistance, especially in Uttar Pradesh. I was over there. But we have overcome that thing. We have overcome that thing. That is a continuous the communication, and this was to the interpersonal communication. That is one of the best way for sustaining the information and the motivating the community. I think that should not be neglected, and we should give in more focus if we want to vaccinate our infants, our children of India to come to 90%.
So just to bring one ground reality to the forefront, because then and now is the thought process that's going on in my head. So polio vaccines also took a number of years for a variety of reasons, but we succeeded. Finally, we got there. Okay. So
yes.
If this kind of communication as it exists in the present era, do you think we could have fast-tracked the kind of...
Sure. We could have fast-tracked, because you see that WhatsApp, the importance of WhatsApp, the good and bad effect that it can spread within a seconds throughout the country. If we give a correct message in WhatsApp, and if it comes from the government responsible self-government or government or NGO with a correct information, definitely it will have an effect on these things. Accepting on a view, because I had an experience, we have done one assessment about the acceptance of the use of the smartphone by the community members for this thing. And we were surprised to find that more than 70% people are using the smartphone. May not be in that way what we are doing, but WhatsApp is very easy. If we have a very, very specific and continuous message through WhatsApp to the community, definitely we will crack that misinformation and go beyond that.
Sure, that's a very good positive point, because when we talk about access, it's also access to awareness and information, and the right information and the right to have the information. So all of these coupled with the new communication methodologies, let me swing to Shaimashri. When we say peer-to-peer, youth for youth, the generation next, if we place them as our wellness ambassadors, what is the kind of experience that you have had? Because typically, youth may not just do Haji and accept anything that you're saying. What are the kinds of rebels within the youth you've had, and the way they communicate? Is it making a terrific impact, not only in their age group, but also beyond, because they can tell their mothers and grannies to change their attitude. So just share your experience on the voice of youth for communications.
Sure. So first of all, many thanks, Dr. Hema, for moderating this panel, and it's my complete honor to share it with Dr. Baswal and Dr. Bagchi. And what you mentioned about Dr. Bagchi, I think the can-do attitude that he displays, I think is probably just one of the few, and it's infectious as well. So I just like to make that mention before I answer your specific question. And also a little bit of note about, how you started on what was happening during polio and what's happening now in terms of communication. So I think when we started on polio, it was information, education, communication. It was because of exactly what you said. People did not know enough. So it was very important to pass on that information. But slowly, all programs, including immunization, moved on to behavior change communication. So it was not only enough to pass on information, but also to give those nudges to change their behaviors. But then in a few years, programs also realized that you cannot just be pushing behavior change. What you have to do is do it in a way that it organically is embedded in their life, right? So which type of society will accept which type of information, communication, behavior change will be different, right? And, in this regard, it's really important to understand that there are two things. We have discussed a lot about media, right? Why is uptaking YouTube or WhatsApp or other social media versus there is still a significant amount of population who's still looking at TV, who's still hearing radios, right? But in all of these media, what thing is consistent is that who is telling the information should be credible and trustworthy. So if it is Mr. Amitabh Bachchan speaking, whether it is some other youth like yourself speaking, who's probably a YouTube influencer with 5 million or 10 million followers, I think that changes from population to population, but we cannot take away the basic fact that I have to trust this person or this influencer because I trust him or her in other matters, right? So, for example, now I think, and it's a bit of an opportunity as well, we have so many successful Olympic athletes coming back, right? So, how can we use them as an opportunity to convey messaging around COVID-19 vaccine, around COVID-19 appropriate behaviors, as well as routine immunization, right?
Absolutely.
I think that becomes very important. Coming to your other point about, the rebel, I mean, rebel is one thing, but I think there's a significantly growing amount of youth, millennials, who want to be purposeful in life. I think there is that shift happening because maybe a lot or a greater population of youth is coming from more stable economic backgrounds. They have had high quality education and they have that spirit of giving back to society. So you will see, I mean, just in the pandemic, there were so many startup organizations, volunteer organizations, which came together to give back to society.
Absolutely.
And that is the spirit of youth of India. And that is something we have to capitalize on in terms of communication, messaging, and a more widespread evolution, right, of public health programs.
Yeah.
So I don't know if that answers.
Excellent. Because see, the celebrities, when they say, just do it, so that is the kind of impact it has, and we entirely agree with you on that point, because it cascades more speedily than what one would imagine. That's for sure. And the proactive youth, which, as you said, they're passionate about doing some things and they're purposeful. So that's also a point well taken, Shaiba. So thanks for those brilliant inputs. And the next round of questions I want to ask all the panelists, starting from Baswaji, about the opportunities that you have had in your position within the government for maternal and child health care, where specific to the vertical of vaccinations, what was that opportunity which still resonates in your mind as one of your very significant contributions? What did you do? How did you do? And we would like to hear more on that.
So, Himad, actually not specific to the immunization, basically, but what we did was that there were a lot of opportunity which was there. Like, for example, one of the program which we rolled out was the Pradhan Mantri Surakshit Matritva Abhiyan. Right. And it's a very very unique program, which is basically combination of government joining with the private sector, and also with no cost. Basically, you are just asking them to the PM made basically a call, and a lot of you know very well that a lot of Foxian actually provided their services free of cost. So that was a very unique program, and basically we conceptualized right from the beginning, and and the way it was done, and the data is there for everybody to see, that we had a lot of people, more than I think quite close to 6,000 people were there who were providing services free of cost. So that was a very typical program, which I think, and that's a great success, let me tell you, because it opens the gate for other partnership which can be developed with the government, with the private sector. I think there is a huge amount of scope which the private sector offers, and I think the government should enter such partnership, because when you are working on a bigger scale, you need more partnerships, and then it you can do it. So I think we did it with a lot of that understanding that how to go about it, and we actually you very well know that at that time there was an ad which was basically not from anybody, but the ad and the major focal point were the obstetrician.
Yes.
Dr. Alka Kirplani being at that time the president.
Yes.
Was there, yeah. So actually, and focusing on that, and we actually developed the software how to capture data. Anybody can go and show, and basically once they actually get into that portal, they can actually log in, and then they can tell, and the CMO gets in touch with him, and he can provide services. So it was a Very well, and I think such partnerships, opportunities are there. And if bigger programs are there, and if you can have those partnerships, that is the way to succeed.
Yeah. Thank you so much, sir, because we were proud to be and continue to be a part of the PMSBA program. And I think that, again, that's a very, positive contribution that the OBGYNs have made, because all the Foxians are always keen on doing something, but it has to be channelized into what they could do and how they can make an impact. And this also brings another additional point which Shaima mentioned about the trust, because the trust deficit will start eroding when you have more partnerships where we can prove that these partnerships are indeed worthwhile to scale and to do more with synergistic effects. So thank you, sir. Switching to Dr. Bagchi now. Implementation is the key, the doing. There is a lot that you have done, Dr. Bagchi, in terms of capacity building. Because it's just not saying awareness, the supply chains are not proper, the people who go, they don't know adequate information and they don't know what to do and how to address. Then it's, we can imagine where the programs would go. So lakhs and lakhs of people whom you have trained to do their job well, which means the to-do factor. So I want you to share your experience on your implementation process, paying attention to those micro details. And also the UP segment itself is like huge. With one state, you could do so much. How could we take the lessons from there to the rest of this complex country, sir?
Okay. Thank you, Hema. In fact, the people used to, my friends abroad, they used to tell, Uttar Pradesh itself is a two country in the Europe. Okay?
Yes.
But to talk about the India, it's like this. Yes, there is an opportunity, but we have to see the routine immunization opportunity in the backdrop of the challenge. As I spoke, the challenge in the community, but challenge in the supply side, because we normally consider one is a demand side and one is a supply side, and supply side challenges are there. The supply side challenges, one of the important challenges is to continuous supply of the vaccine. You are seeing in COVID vaccines that tomorrow 5 million doses are coming, tomorrow, day after tomorrow, there is no doses are coming. But in routine immunization, you can't do like that. There should be a sustained supply of the vaccines right from the Kashmir to Kanyakumari and Arunachal Pradesh to Gujarat. All these 14 points. And we know that we have 29,000 vaccine storage point in the country where the vaccine has to be supplied, because it is vaccination is a timely business. Okay. So you can't delay the vaccine. So that is one of the biggest challenge. Second biggest challenge, of course, it is a huge number of the healthcare worker who are providing the services, and they need to be trained, because they are the technical people need to be trained. So these are the two challenges. But if you see the opportunity in India is like that. I must say that although we have started from the 1985, the UIP program, Universal Immunization Program was started. But there is a boon. In fact, there is a tsunami of the new vaccine introduction right from 2014 on 15 onwards. In 2015, the IPV was introduced because India has already become polio-free 2014, and 15 additional vaccine has been used to protect the Indian children from the polio from abroad. That is one. 2016, there is a new vaccine has been introduced, that is a rotavirus vaccine. Since I was associated with the rotavirus vaccine, I am very proud to say that 49 countries of the world, they have started the rotavirus vaccine out of 264 countries. India was one of them. That is the thing. 2017, the measles has been replaced with the measles and rubella. Being a gynecologist, you know the importance of the rubella is there, and also the PCV vaccine. And the PCV vaccine, that is a pneumococcal vaccines for this pneumonia. 2018, the tetanus toxoid has been replaced with the TD. That is because there is also of diphtheria of the neonates as well as pregnant mother. And 2019, the whole country, the rota expansion was there. And now we are expecting in 2021 or 2022, the PCV expansion will be there. So there is a huge vaccines are there. But definitely one information through this channel I wanted to tell to the people of India is like that. If you calculate the cost of these vaccines in private sectors, it comes to thousands and thousands of rupees. Government is giving all these vaccines free of cost. That is one. The vaccine has been stored is one of the best cold chain in the world. We are having a storage facility. We are having a BVM facility for which the health worker knew that whether the vaccine has been damaged or not. That is the thing. And the cold chain is being maintained right from the manufacturing firm, the company to the lowest point with a continuous temperature controlling and all these things. Now EV has been introduced, data logger has been introduced. These are phenomenal changes in a country like India. Mind you, we have to understand that thing, our cohort or our responsibility is much, much bigger than any of the countries like that. Okay, so that is the thing. Yes, capacity building is one of the most important part for the healthcare worker for giving a quality vaccines.
Yes.
Capacity building, India government is continuously supporting the state and giving funding and the technical guidance. But due to COVID-19, the whole capacity building exercise has become stopped, all these things. So now it is an era of the virtual capacity building is like that. So I must say that there was a program. Fortunately, I was leading that program. It is Rapid Immunization Skill Enhancement Project, which is called RISE, which has been piloted in 5 states of the country. It is purely on the digital platform, and it is purely a self-learning platform. And everybody should be happy to know that there is a certificate generation is there, and the more than 90% of the ANMs or the healthcare workers of the 5 states in India, in one district of 5 states, they have successfully completed the course and they have downloaded the certificates. So I think that we have to go for a capacity building exercise in a virtual mode. As far as the UP is concerned, yes, I am in the Uttar Pradesh. Although we are working for 100 blocks in 34 districts, but UP having 75 districts, and it is a huge, diverse area. It's like that.
Yes.
So we are also planning to start the capacity building. Already government of UP has already built the capacity of the district immunization officers. Of course, it was not the virtual mode. Previously, COVID-19 vaccines, I was one of the facilitators. We have done the COVID-19 training to the district people, sub-district people by virtual mode. I think that we have to go for a virtual mode in a much user-friendly manner and become more attractive. And definitely, it will help us to disseminate the content very fast. Over.
Excellent. So here again, 2 small questions. When you said that this digital platform, yes, that is the way forward, and I'm really impressed that so many could, successfully complete and get their certification. So what is the plan to scale this up? If it's happening in 5 states, why not in the others? That's the first question. And secondly, again, the problem that Dr. Baswal mentioned about the languages. Is it available in a multilingual? Because we do a lot of staff training on quality accreditation program called Manyata through POXI, and we have sorted the batches as Tamil batch, Kannada batch, Marathi batch, Hindi batch, because the staff nurses need to be told in their language, otherwise the skill transfer doesn't happen because they cannot relate to even a single sentence in English that we speak. So how are you trying to get these issues around?
So thanks to this question, because this is also very dear to my heart, because we started from the scratch in 2018 by funding by the Gavi. You see that the RISE project is being operating now it is full-fledged operating in the 5 states of India. Right from Himachal Pradesh is one of them, and the Madhya Pradesh is one of them. And it is the Chennai is one of them. One of the states is like that, and Odisha is one of them. And another states. So in every state, it has been translated into the local language.
Excellent.
It took us 9 months.
Excellent.
To prepare the module and also to digitize that module. You see that the preparation of module is not very difficult for us because we are in the donkey's years in immunization. But digitize that module and make it an user-friendly, that the health worker they can start by first is reading material, video there. And if they feel that, yes, okay, it is over, and I have something to do, I have to cook, I have to go somewhere else, they can stop. And then next time when they open, it will start like this. So it is there. And there is a built-in monitoring system we developed, that we knew that what are the timing the health worker, what are the total time spent by the health worker. You cannot go fast, because that is one of the problem of the digital media, is that during the last session, I will just make my cursor first. You can't do like that. It will not work. And then you have to there is a small questions are there. And in every chapter, there is a question, and every module, the total marks will be calculated and automatically certificate is being generated. So it was very successful. Now it has been, Government of India is trying to scale it up to the other states like that. My colleague Partho Ganguly, to whom I have given the charge, he is now, and he is more competent than me. In fact, he has started this thing, he has expanded this thing in Himachal Pradesh. I knew that Himachal Pradesh government was asking the fund, and definitely if the funding support is there, and it can be translated, and there is a voiceover in different languages. It is not the reading material; it is a voiceover is also there. So it is possible. In fact, what we are very confident that this type of digital platform in local language, it is possible. That technology is available in our country, and the end users with little training, they can utilize this service very well. Thank you.
Excellent, excellent. So next time when we say we are proud to be Indians, or I'm a proud Indian, all of these thoughts also will come into our mind to speak with a lot more conviction. This was such a delightful piece of information, because that's where the need is. Use the digital technology to reach as many, and don't be surprised that there are so many takers, because there are so many takers who are just waiting for the opportunity that you present to them. So let us, especially the people who are not so tech savvy or digital savvy, they're very skeptical about whether this would work, and then there is no personal interaction, and what will happen, and whether there be anything, the impact of this will be good. But you have done it and proven, and also the language barrier, which you so beautifully brought out, that it's easy to prepare the module, but to translate it, because if you just use the traditional translation, some of the words, they need to be read again and then, re-revised to make sense. So that is, that's really commendable. And I do hope that bit by bit, we will cover all the states and empower many, many more thousands and lakhs of healthcare providers to offer their best. Shaima, again, back to you.
This is made in India. Mind you,
yes, yes, that's why I said that we're very proud to say that, because I think the complexity of the languages itself is very baffling to the Westerners. They're saying like, how is it that, in this part of India it's this, and then so many languages we have that also they cannot digest it. Even until today, many of my international colleagues, they say, with each set of people we are speaking differently, and they cannot come to terms with that. So this is, it adds to the challenge, but we are ready to take the challenge and leap forward. So, which is a great thing. Shaimashri, again, the question to you is that the infant and the child vaccinations, that is a mindset is there, and it's a given, and then all the parents want to do the best for the child. A little child, he doesn't have any say, it goes and gets the vaccine done. But when it comes to the adult vaccination, maybe HPV vaccination, for example, or the pregnancy vaccination, there could be, again, a lot many more facts to make it not so successful or impactful. So what is your take on the experience that you have had with other kinds of leaving the infants and the children, moving beyond to adolescence and pregnancy? What do you think will work there?
Thank you, Dr. Hema, once again. So again, I'll go back to from where you started, that, it's the same woman who gets married, who has kids, who has, and it's a cycle. So
absolutely.
Even when we were looking at childhood and infancy vaccination, I think what was a strong element which was missing earlier, but at least in the last couple of years, there is intensive evidence generation happening, is using the gender lens, right?
Yes.
And so what happens is, I mean, if we look at our typical surveys, like National Family Health Survey, in terms of immunization and gender intersection, you'll collect two types of data. One is how many boys versus how many girls were vaccinated, and what was the level of mother's education. But if we take a deeper lens, that is not where gender stops impacting immunization or public health service delivery. There are a lot of other intersections which happen. For example, what is the agency of the caregiver? Is she involved in household decision making, which then cascades to household healthcare seeking behaviors? Does she have the agency to take the child to an outreach session for vaccination, and many things like that? So once we start applying those lens and those intersectionalities, what we see about adolescent vaccination, what we see about maternal immunization can be much more clearly understood. So if as a caregiver, I'm not able to advocate with my family that my young 1-year-old or like few months old child needs to be vaccinated, just imagine the amount of challenges I'll have to face if I need to vaccinate my 9-year-old for HPV. Right, and HPV, there is a host of other social stigma associated. That if it is transmitted sexually, then are you promoting early sexual, behavior, and so many other things. Then there are so many girls who drop out of school. Worldwide, HPV strategy is do school vaccination, school-based vaccination. But that might just fall flat in situations or in communities where majority of girls drop out. So I think gender, not only based on the gender of the child, is an important factor. Gender goes much deeper, and that's what we need to understand, and more so in the communities which are left out. So again, worldwide, there's a lot of focus on zero dose and dropouts. I think here, looking for more evidence will also give us the answers to what will work for adolescent vaccination. In terms of maternal immunization, actually the country has done well. I mean, we have eliminated maternal and neonate, like MNT elimination happened, I think 5-6 years back. So we have advanced, and it is one of our strong programs. But then we don't have to only restrict itself as maternal immunization. You have to look at it that this is one female who has already been tapped by the health service vertical. Now, how do you engage other programs so that they can also be done? And very good example is birth dose immunization. So typically, birth dose immunization doesn't happen at the facility. The immunization program is very comfortable in seeking newborns in the community, and within the first 15 days, they'll go and do the birth. But if you look at it from the person's angle, you have already advocated to that person that take your tetanus during maternal, right?
Yes.
In some cases, flu also, like a lot of private sector are now administrating flu vaccines.
Yes.
But you are not including birth dose vaccination as a checklist in maternal programs, right? So ANMs in delivery rooms, etc., don't check it. Their capacity building is not as much. So these are the small fixes we can make, which will have massive benefits. And you're continuously telling that person that immunization is important throughout the life cycle. It is not only during pregnancy. It is not only when your child is 6, 10, 14 weeks. It is not only when your child is 9 to 14, whenever HPV comes. At every stage, vaccination will help you or your near one. So I think those are the challenges. I mean, it's not that there is not cognizance. There is cognizance, but it's not widespread. And we need to, get more evidence so that we can make it widespread.
Sure. Two very, very important takeaways from what you have said so eloquently, Shaima. One is the integration. It's the same person. So, you take her whole life course or life cycle approach to whatever you need to do with her. And also the fact that beyond just the male and female gender, there is so much more in the decision-making process. Who commands? Who has the right to say, yes, you can do it? Because most often it doesn't have. Though the next generation is getting slowly and steadily educated and empowered to do so, but we are not yet fully there. So we need to focus on that aspect as well. Wonderful. So the last round, to my very special three guests here, Dr. Baswal, I want to now go to another angle. You're dealing, of course, with the community, but you're also dealing with the segment of healthcare providers, including specialists and Foxians. Sometimes we become the barriers. There is not enough uniformity in what we voice out, and that sometimes creates a little bit of a setback or a confusion or chaos or whatever you may call it. So some new vaccines introduced, even for pregnancy and lactation, the COVID vaccine, for example. So what has been your experience with the healthcare providers, the specialists, and the peer groups like ours that you deal with? How much of troublemakers are we to the government itself?
So that's a very interesting question, Dr. Hema. I think what you have to do is that a program officer has to have a grip on deep understanding of the program, right? Yeah. You can call, and any situation you will have, I think, divergence of opinion. Now you have to take a call that whether this divergence of opinion is right or wrong. I can give you a very, very good example. When we started, I think when we had this program of syphilis elimination, HIV elimination,
yes.
And that guidelines came out in 2014. Now, in that also, one of the things which we were planning was hepatitis B elimination. Okay. Now, what we were looking at is, do we vaccinate the woman? Because in globally, hepatitis B is also given, right, in number of countries. Now, when we delved deeper into it, and when we actually, consulted a lot of experts, we found out that this chain can be broken if you give the vaccination to the child within 24 hours. Hepatitis B vaccination is given within 24 hours. So intervention was not needed at all. So the point is this, that you may have divergence of opinion. Get your as much as possible. I think what we have to also understand is consensus building is the key. When in the medicine or in scientific when we do anything, there will always be divergence on opinion. What you have to see is whether that is substantial or not, and then take a call. And if we at the ministry, we actually have a program officer has a lot of these problems at hand, and they have to handle day in and day out. So they have to have a deeper understanding of whether this is what they are talking about is actually basically an issue. That's the first thing which they have to understand. And if it is an issue, it is going to be a barrier, right, like that. But divergence of opinion, in my understanding, is that it will always be there. You have to take a call that how to address those barriers and all those issues in especially with the providers.
Yes, I very fondly and clearly remember the syphilis issue when we were all called for a consensus meeting. Yeah. And it's so important to call for those consensus meetings, because then we can voice out that yes, there was these kind of discussions, but finally this is what we've agreed upon, and this is how we will move ahead as a professional organization. That was the key, because the VDRL testing itself, when it was explained that it's a low-hanging fruit, and then all of you do it, and then we can eliminate this once for all. So those kind of thought processes are like so very crucial, and the same happened with the debate on whether pregnant women should be given the COVID vaccine or not. Therefore, the lactation vaccination for those who deliver in the institution, which is again a low hanging because they are available to us there. They can have one jab and move out. So that was the first, success that we achieved. And of course, we then spoke with a very strong voice for advocating for the pregnant women as well. So I agree with you that, all the meeting of the unlike minds has to happen to come to a consensus for a common good. Thank you, sir. Point well taken. Dr. Bagchi, any experiences where you have fought the battle with the other side of the coin, the supply side? They are kind of not fully convinced about what they have set out to do, and how do you train their mindset for their behavior change?
You see that supplies, yes, you see, if you talk about the routine vaccinations, because we have to dissociate from the COVID experience to routine vaccinations.
Yes. Mm-hmm.
Supply side, you see, per se, I have not seen that there is any discrimination of giving vaccines. Yes, there is a discrimination, but in a different perspective. When the Rota was introduced in the country, there was a Rota vaccine is costly, everybody knew. And there is a message has gone to the health worker, that this vaccine is very costly and it has got no dose should be missed. So what the health worker used to do is like that, if the 2 or 3 children comes, she insists ki you stop or you come somebody else. Not per se, because that was in mindset. In fact, our immunization program, the national guidelines says that even for one child will come, you have to give vaccines. So it is a question of behavior change communications, and definitely after a lot of push over there, so that has been stopped. It's like this. And of course, there is a challenge sometime for the supply of the vaccines, because we have to understand the vaccine manufacturing backgrounds in like that. It is not a drug that in overnight it will be prepared. And I must be very proud because I was associated with the program at the national level. So I must say that in India, all the vaccines which has been routinely, or COVID, whatever you call it, when it is prepared, it has got a very stringent quality control mechanism, which is in Kasoli in the Himachal Pradesh, and every batch testing is being done and then it has been circulated. So it takes some time, and which we are seeing in COVID vaccines. So quality have never been compromised. I never seen such a poor quality of the vaccines. Yes, there was a catastrophe, but it is due to the programmatic error over there. So it is not like that is going on. That is one part. Second part, yes, of course, since you know that it has been spread to 29,000 cold chain points right from the state headquarters to the district, then to the block, and even in some of the state in Assam, it has been transported through boats, and the difficult terrain in Gujarat, it has been transported through animals and all these things. The bulk vaccine I'm talking of. Right. Yes, there is a supply challenge, but per se, I must congratulate Government of India that there is no discrimination of the childhood vaccine to the state, but definitely there are more. We have to work more, because if the demand is being increases, definitely we may face a breakdown on the supply challenge. Over.
Absolutely. Dr. Bagchi, when we listen to you and your pride on the quality that, you vouch for and the positivity that you generate, and therefore it's a little wonder that the implementation has actually, happened, because with this kind of a mindset and the belief in yourself and what you're set out to do, I think it makes a lot of difference. My last quick question to Shaimashri, because you mentioned about the evidence generation. I just want to pose in the light of the COVID-19 vaccine. Of course, as how it has been discussed in the previous panel, the hesitancy in the villages is far less. They're just taking it, but even abroad and even in many of the metros, okay, there are like some divided opinions about what to take, when to take, whether to take it or not at all. So I want to place this in the context of HPV vaccines. We have had these HPV vaccines for a decade. We have had enough evidence and robust evidence, and the safety also. And this, it could be a reality 2030. We can just eliminate the HPV infection itself. There is an opportunity for that, but that's not getting accepted. Whereas the COVID vaccine, we've gone on a fast track, and there's enough that is happening, and many more have been covered than what we anticipated. So where is this difference? What is it? Is it again the gender? Because it's not a gender neutral vaccine that we are advocating yet, because it's only the girls who have to be given the HPV, or what do you think is the bottleneck there?
Yeah, so there are multiple bottlenecks, and I think the global community is smarter from the IPV vaccine shortage experience, which panned out a couple of years back, and there was, manufacturing sector delays. So although IPV switch had happened, was introduced in a lot of countries, there was not enough vaccine to meet that demand. And India actually innovated, right? We went ahead with a fractional IPV dose. With HPV, it's a similar supply shortage situation. And in that sense, the COVID-19 pandemic, still forcing us to go on a full-blown vaccination campaign, even though there are supply shortages. India, because of its muscle, is still managing to vaccine a lot of its population. You can see what's happening in Africa because of the global vaccine shortage, right? So in HPV, vaccine supply shortage is a big factor, and that's why global community is also not advocating that much with that type of rigor till the supply situation is stable. The second is, what type of vaccination strategy do we employ, right? Do we only vaccinate 9-year-olds? Do we vaccinate 9-year-old and do a catch-up for 10 to 14? Do we do 1 dose? Do we do 2 doses? Because if you remember, originally it came as a 3-dose vaccine.
3 dose, yeah.
Then there was evidence which said that even 1 dose, 2 is fine.
Now it's 1. Yes.
There is 1 is also okay.
Yes.
Then there is that, at least in the context of India, we have a established infancy immunization platform, right? We know how to tackle it in facility as well as outreach. There is no such platform for adolescent, right? And I was alluding to it a little bit earlier, that do you go to the schools? If you go to the schools, how much percentage of girls will you cover? Will you not cover everyone? So the the strategy of implementation itself doesn't have a full-blown consensus yet. So I think these are the couple of challenges around HPV, and I'm not at all mentioning the social barriers. That is like a huge impact. There is, of course, a pending court case. Litigation is happening in India around HPV. So once that is over, we'll probably have a stronger green signal. But yeah, I think slowly and steadily we will get there.
Sure. Thank you so much, Dr. Baswal, Dr. Bagchi, and Shaimeshri Das, for your very insightful and very positive, forward-looking inputs. That yes, we started way back there. We had our limitations, challenges, but still we did a lot that many other countries could not do. Digitalization has played a very important part in the awareness communication strategies. The capacity building too has moved to the digital platforms, the public-private partnerships which Dr. Baswal mentioned, and the youth community joining hands to do more and to do better. And I have no doubt that we will be setting a role model for the globe, that despite if these challenges were thrown into any other geography, any other countries, I think we would score a huge margin over them. So with that positive note, I come to the close of this panel on challenges, opportunities, and needless to say, the great impact that we will continue to make in this space of vaccine in this great country. So Baswalji, Bagchi and Shaimeshri, thank you so very much. Thank you. And as I can see, my very beloved Professor Sanjeev Kumarji was all set to now blow it up in the next panel with my very good friend Dr. Ravi, whom we call Virus Ravi for a long time. He has joined in too. So over to you, Dr. Sanjeev Kumar. Namaste.
Thank you. Thank you. Thank you.
Sanjeev sir, I request you to please unmute yourself.
My apologies. I didn't realize that. So thanks to Hemaji and Dr. Dinesh Baswal and other friends on the panel. I really enjoyed listening to you. It's time to move on to the next panel, and we have very renowned people on this panel who are well known not only in India but globally in the field of immunization, and have been in the forefront both in the government and outside the government. Those who are outside the government, they have been part of many task forces and expert panels guiding the whole initiative on COVID-19 and COVID vaccination program. So I welcome all the panelists. So brief introduction of all the panelists. They have a very rich experience, but I will try to capture the main points so that you know who the experts are on this panel. We have Dr. K. Madan Gopal, who is a renowned public health expert and is well known for his work on issues related to health system reform and strengthening healthcare delivery in India for almost 3 decades. He has held many leadership positions, and many of these positions have been very demanding. He has been playing an exemplary role in guiding many of these initiatives. He has been one of the pioneers in Rashtriya Swasthya Bima Yojana, world's largest health insurance scheme, before it merged into Ayushman Bharat. So it is natural for him to move from RSBY to Ayushman Bharat, which he is contributing as of now. He is currently I think there is no better place than Niti Aayog for a public health person to contribute to COVID-19 and COVID vaccination, in addition to other areas related to health in the country. Welcome, Dr. Madan Gopal, and I am very grateful all of you have spared your holiday. Saturday is weekend in Niti Aayog and many other places. So thank you so much. We have another friend, well-known friend of mine, Dr. Raj Shekhar Ghosh. Welcome, Dr. Ghosh. He is a senior advisor in vaccine delivery in India Country Office of Bill and Melinda Gates Foundation, and we have interacted a lot on immunization and related issues in his office on many occasions. He also brings in more than quarter of a century experience of working in public health, right from grassroots level. He has been at PHC level, and he is now at policy and national decision-making bodies, guiding many non-governmental organizations, state health services. He has also been part of PATH, which has played a very important role in advocating and promoting many of the vaccines we have today in use. He has also been part of National Polio Surveillance Program of WHO, and that program has contributed to eradication of polio in India, and hopefully Pakistan and Afghanistan will soon see the last cases very soon, despite all the disturbances they have. And he has been in WHO as regional coordinator for Southeast region for polio, has been technical director of immunization in PATH, and director of multi-country Japanese encephalitis project for Southeast Asia and Western Pacific region. So if I go to details, it will be a very long list, but to name and some more areas. He has been a keen researcher and has been involved in doing research on visceral leishmaniasis, popularly known as Kala Azar, and it's a disease we are struggling with in India. He has contributed a lot in research and treatment for that. His current focus is on advocacy and evidence-based policies and capacity building, and he has been conferred with fellowship of Indian Public Health Association. Welcome, Dr. Raj Shankar Ghosh. The next person is Dr. Ravi Vasantapuram. He is a renowned neurovirologist and a member of the State Technical Advisory Committee in the state. He heads the neurovirology department of NIMHANS, another renowned institution, not just in India, but globally. He is currently holding the charge of registrar in that institution. He has been involved in extensive research and clinical work in diagnosis and treatment of various viral neurological infections of public health importance in the country. He has collaborated with the University of Liverpool for more than 15 years as co-director of a dual PhD degree between NIMHANS and Liverpool Institute. Another friend of mine, Dr. Chandrakant Laharia. Dr. Laharia, welcome on this panel. He is widely known as a prolific scientific writer. Has written extensively on COVID, and most of you may have seen his book. He has written jointly with Director of AIIMS and Dr. Gagandeep on AIDS, and one of the most comprehensively written book which looks at all aspects from community level to policy planning level when it comes to AIDS control. Dr. Laharia is a medical doctor, epidemiologist, vaccinologist, public health and policy expert. I have already talked about his writing skills, and he is also extensively writing in popular media, in newspapers and magazines. So he knows inside out about how we have been doing in the COVID fight in the country and beyond. Dr. Laharia joined WHO in early 2008 and was working there till recently, and he coordinated organization work in introduction of new vaccines such as Haemophilus influenzae B, popularly known as Hib vaccine. Welcome, Dr. Laharia. And last but not the least, we have a very renowned public health expert, Dr. Farzana Islam. She is professor and head of the Department of Community Medicine at Hamdard Institute of Medical Sciences and Research. She is an academician and researcher of repute. She is known as a public health expert for more than a decade after finishing her MD, and is involved in teaching and research. She has also been part of WHO's National Polio Surveillance Program, and that's when you come to know the details at community level, from community level to the policy level when you work in an area like this. She has been a member of multiple professional bodies and contributes very actively to their work. Indian Association of Preventive and Social Medicine, Indian Public Health Association, and Indian Association of Adolescent Health. Welcome. I am also a co-member. I'm sure many others are also members of these professional bodies. So good to have you on this. She is actively engaged in nutrition areas and a member of IAPSM group, which looks at micronutrient and infant and child nutrition. You're welcome to this group. She has many research projects funded by ICMR, WHO, Alive and Thrive, and so on. So I won't be able to give all the details. Welcome, Dr. Farzana. So maybe I'll request Dr. Madan Gopal to be the opening batsman. So
Giridhar Babu needs to be introduced also, I think.
Pardon?
Dr. Giridhar Babu.
Oh, I'm sorry. Yeah. I was. Yeah. So I don't have his details. My apologies for that. Dr. Giridhar
Everybody
Babu,
knows him.
Yeah, he is well known. He is professor and head of life course epidemiology at the Public Health Foundation of India, and is also a member, in recognition of his expertise, a member of Indian Council of Medical Research National Task Force of COVID-19. Welcome, Dr. Babu, and my apologies for missing you. So we'll come back to Dr. Madan Gopal. for his insight into what were the gaps in COVID-19 in our fight against it, and also in COVID vaccination program, because you are at the helm of affairs in Niti Aayog, so you can give us a lot more insight into not just the people who are listening to it, but also to the expert panelists who may not know some of these areas of Government of India's involvement. Over to you, Dr. Madan Gopal.
Okay, thank you, Dr. Sanjeev, and good afternoon to everybody. First of all, thanks for giving this opportunity to speak at this occasion. First of all, please accept my congratulations. We all should be congratulating ourselves. Yesterday, we added one more vaccine to our list of vaccinations. That's the second indigenously produced vaccine, which is now part of the COVID vaccination drive. That means we are having one more vaccination, taking the total to 6, which have been approved to be used in the country. Okay, having said this, having congratulated all of us, because that's a very big achievement. 54 crore plus vaccination jabs, that too indigenously manufactured vaccine. Some of the jabs are Sputnik jabs, but it's all indigenously produced. Had it been an imported vaccine, had we been dependent on imports of vaccine, then you could have imagined a situation where whole of the globe is struggling to have vaccination done for their population. Everybody is trying to get as much as vaccine shot possible, acquired. That kind of thing is there. And in this background, I will just take you the journey of the vaccination before I come into the gaps in the COVID and other things, which have now tremendously improved. So initially, when we started, the journey started during the month of May, June, with the constitution of a committee. We should be focusing on areas like therapeutics, diagnostics, and vaccination. To aid this thing, a biorepository and the exchange of specimens, that kind of guidance note was made and the policy was made. As a result, there was a sharing of these biological samples, and that has enhanced the process and enhanced the coordination between the different organizations. You have DBT, you have ICMR, you have NCDC, you have the ministry, you have the hospitals. From how to coordinate all this thing, and you are having the CSIM and the other laboratories. To have that thing, we have that biorepository policy, and that has aided in the expediting the understanding, getting the research studies done. And as a result, we have been able to culture the virus. The ICMR was able to culture the virus, and the other things have happened. Apart from this, after the constitution of that committee, there was one program, that's COVID Suraksha program, for at least ramping up the manufacturing capacity, as well as helping the manufacturers to come up with a vaccine. That program is now yielding result. You have seen the Zydus Cadila now. Now you will be seeing the biological E vaccine, which is in pipeline, and that kind of other initiatives. Covaxin also, you have seen how things have evolved after that, and it got a impetus, and the things got expedited after the announcement by our Honorable Prime Minister from the ramparts of the Red Fort last year, and subsequently a national expert group on vaccine administration was created, which oversees which of the vaccines which needs to be brought into the country, and the other nuances of vaccination program. Even what platform, what IT and other things were to be used during that program, that was being guided by this NACVAC and other things. So after lot of things, lot of deliberation, when it's not that we were only focusing on the indigenous vaccination, the efforts were also made to see that how the vaccines which are approved elsewhere, they can be brought to the country. But the problem is the finite supply of the vaccines. All the countries, they are struggling to have a stockpile of vaccines so that they can give vaccination shots to their own population. With this background, when things started moving, when the other nations started, the clinical trials started, and the the vaccine, the other countries also, they have started the vaccination program. In December, many of the countries, they have started many of the countries which were far ahead in the clinical trials, they got the approval and they started the vaccination program. Our vaccination, we started from the 16th of January with the healthcare providers, which has happened elsewhere also. The first priority group was the healthcare providers, which was then extended to the first frontline workers and the seniors, that is 60 plus population, based on the morbidity pattern which was observed. And a similar kind of strategy was adopted by other countries. Initially, we started with the Covishield, that's everybody knows. Then Covaxin got the permission, then the Sputnik. And after that, permission was given to Moderna. Cipla has got the permission to import that vaccine. And we have yet to see that. Johnson has also got the approval. It would be supplied to one of the manufacturers here. Then yesterday we got the clearance for the Zydus Cadila. And one of the interesting things is that indigenously produced vaccine, which can be used for people more than 12 years of age. That means a sizable population of the pediatric age group can be covered through this vaccination. And we will appreciate that through these two indigenously developed manufactured vaccines, we have been able to inoculate 54 crore. We have been able to give 54 crore doses in the last 8 months. To handle all these operations manually is quite difficult. When the deliberations were going on, so we thought that we should be having an electronic platform or electronic thing to monitor and to aid that thing. In the immunization program, we are having the EVIM platform. So we thought that why can't that be improvised and adopted for this adult vaccination? While the preparation for vaccination was going on, side by side, the cold chain equipments, the requirements, and other logistics were going on. It's not that it was a sequential kind of thing. Parallelly, lot many activities were going on, right from IEC, right from the logistics. But I would be restricting myself to the COVID, this how the COVID evolved. First was the first discussion started with having a beneficiary database, how to have that database entered into an electronic software. So this was readily available software which was ministry was using for the universal immunization program. It was adopted. First, a beneficiary module was made, and since this kind of program where we are targeting more than 90 crore population by end of December, to handle that database, we require a platform which is quite robust and which can handle all the logins and the other things. If you want to understand it, so we are having a capacity of having more than 1.5 lakh immunization sessions in a day. To handle that sessions, if 1.5 lakh people are handling or logging at one place, you have to have a system robust enough to support that kind of thing. So what has happened after adoption of that, after the beneficiary module was there, initially there were some glitches and other things, there were delays. Now, as the platform evolved, now most of the glitches have now been addressed as the things are evolving, because these are things usually evolve and they get mature. As the thing is as the platform is evolving and it is getting mature, the robustness is now getting proved. Now you can schedule a vaccination. Now even you can have an outreach session, you can have bulk session, that kind of facilities as and when required, it is getting customized. Based on the success and the robustness of this has been showcased, and many other countries, they have also shown interest in adopting this. So initially there were gaps. Dr. Sanjeev, you had told about the gaps. Initially there were gaps, as happens to any other program. As you might, everybody wonders that the vaccines were given very fast approvals. As the vaccine, because of technology, we are now having confidence that it can be given approval. For any software of this kind to evolve that too in a short time span of 3 months, because the effort started in October and we were in a position to roll out in January. After that, things have evolved. For any software, initial glitches are there. We have also experienced initial glitches. Now the software is now evolved. It is getting mature, and now we are confident that it can be offered to other patients so that they can adopt and that they can run the adult vaccination program or other vaccination program. The beauty of this platform is that you can schedule immunization sessions. Otherwise, scheduling an immunization session, that too on a daily basis, it's a very hell of a job. We have 2 days immunization session or 1 day immunization session a week. That was used, but it was very difficult. But having traveled this journey and looking at the horizons, the number of vaccines which are available, in the coming days, you will see the number of vaccination. Currently, we are inoculating 40 to 50 lakh, 40 to 60 lakh vaccination shots per day. So in the coming days, with as the availability and the number of vaccines increase, we will be seeing a quantum jump in the number of people who are going to be getting vaccinated. This is all from my side. Thank you very much. Over to you, sir.
Thank you so much, Dr. Madan Gopal. Three quick things I capture from what you said. Indigenous production of vaccine. In the shortest period of time, we have come up with the Covaxin, the locally developed vaccine, less than a year after isolation. That's a great achievement. India was already a hub of vaccine production. They often refer to India as the dispensary of the world, but we are also vaccine hub of the world. Even before COVID struck us, 60% of the vaccine used anywhere in the world came from India. And we leverage that capacity in a short period of time to come up with a large amount of vaccine to meet our local need, but at the same time be ready to export to other countries. Second point you mentioned, we again built on our capacity. We had a app available for routine immunization program in India. And then this was expanded to become one of the best platforms available in the world. And it has become a global good practice. Many other countries are looking at it. Yes, things were tough. We were all caught unawares in India as well as in other parts of the world. But there is a saying, when things get tough, the tough gets going, and they have really come up to that expectation. And one of the institutions which has led that is Niti Aayog. And thank you so much, Dr. Madan Gopal. We will come back to you for the second round of your input. We have Dr. Ravi, who, as I introduced you earlier, is also on the State Technical Advisory Committee. So you can bring in some more insights from the state level as well as your other experiences on dealing with gaps in COVID management and also with the COVID vaccine. Over to you, Dr. Ravi.
Thank you, Professor Sanjeev. Thank you for having me on the panel. Let me first start with gaps. I think the gaps that lessons on the gaps we learned after the second wave is that advice from experts should be taken seriously. Several experts, including, at least in Karnataka, myself and my good friend Giridhar Babu, had been warning the state that we are in for a second wave. So I think that is one important thing. We should keep monitoring the test positivity rate. 7-day moving average is a simple tool, and that is something that all states have to do it. Every state should have a technical committee comprising of virologists, public health specialists, clinicians, policymakers, administrators. And this group should be looking at data and advising, and all intervention should be data-driven. That's number one. Number two, I think the biggest lesson for all of us from the two waves is that COVID-appropriate behavior, more easily said than done, is very important. But more importantly, until a sizable population is immunized, we should avoid crowds, crowding, congregations, and gatherings in closed spaces. Now, this is something that has been repeatedly told and written about, but the argument has been economic activity. So one lesson that we have learned is both lives. In the first wave, we gave importance to lives. In the second wave, we gave importance to livelihoods more. But I think there is a middle path that both lives and livelihoods are important. The third thing I want to say is that testing should not be lowered. Testing is the main weapon we have. If we have to stay ahead of the virus, we have to be testing adequate numbers and the correct populations. So all symptomatic people should be tested. That is top priority. Second is all groups where people engage in behaviors that include interacting with crowds, contact with many people, they should be tested. So testing should be maintained. As a public health expert, I need not tell all of you that the thumb rule is for every positive patient, we should ideally try to test 20 positives. So these were, and I think the biggest mistake we made in the second wave is congregations and persisting with rallies and gatherings, be it political or religious. We went on with it in spite of Maharashtra giving us a warning early. I think we have learned a lesson. I'm sure we will not repeat that. Coming to vaccine, the other major thing, which is my area, is what caught the world unawares are the variants. Emergence of variants. The virus will continue to mutate. That's its business. It will continue to throw out new variants because it is survival for the virus and the fittest will survive. All the variants that have come up have been more infectious than the parent Wuhan virus, starting with the UK variant, which is called Alpha now, and then the South African Beta, the Brazilian Gamma, and of course the world famous Delta, which was detected first in India, which is now sweeping across the globe. So I think variants will continue to emerge, and we should be aware that we will not be able to get protection against infection with variants, but thank God all the vaccines are giving protection against severe disease and death. And the last thing I want to tell about vaccination, a lot has been said by Dr. Madan Gopal, is the whole world is facing a shortage. So I think what people are looking now is mixing and matching. So mixing and matching, there are several countries which actually have given a policy that vaccine should be mixed because of the shortage. There is enough evidence to say scientifically that mixing vaccines, if you make the right combination, you will have a much better immune response. The worry of more side effects has so far not withstood the test of time. The amount of side effects by mixing vaccines has been not more than what it is with the parent virus. And last, of course, is the question of a booster, which I think the time is come now for dialogue on it. There are studies that have been initiated, but I think we need more data. I'll stop here and thank you for giving me an opportunity.
Thank you. You very clearly identified 3 gaps in the program and 3 gaps in the vaccine, and also given us way ahead on those. Second wave, we were not prepared. We'll let things loose. The bureaucrats and politicians did not listen to the experts. They must listen to the experts. Second is vaccine are important. The strategy should be relying on the vaccine, but at the same time, when vaccine is being scaled up, even after it is scaled up, continue to follow the preventive measures, because you don't know when the variant will come which will bypass the vaccine. Testing not to be lowered, because that's how you will come to know the cases and how many people they have spread cases, and then from where the infection come, and then you can control the spread of infection. Vaccine shortage, mixing and matching, there is work going on. Some of the countries are ahead of it. They have allowed. We need to take a decision on that in India, and also start a dialogue on the boosters. Thank you, Dr. Ravi Vasantapuram. We'll come back to you in the second round. So the next expert we have is whom Dr. Ravi also mentioned is a member of the Karnataka task force with him, Dr. Giridhar Babu. Over to you, Dr. Babu, for giving us some insights into the gaps and what can be done so that we don't suffer from these things in future. Over to you, Dr. Babu.
Thank you, Professor Sanjeev, and all the esteemed members on the panel. It was mostly a manel. Thank God there is Dr. Fazana who is saving all of us because she's on the panel. I hope she gets more opportunity than any one of us. So answering this question on what gaps are, See, most of our programs are centrally sponsored, right? So, which means the funding comes mostly from the center. But sometimes the agony or the pain in public health is that even the knowledge or the wisdom also comes only from very top level downwards. And as practitioners in public health, we have been advocating that it has to be bottoms up, evidence-based approach, which is culturally appropriate and contextually specific. But very rarely that occurs. I'll give you an example. Right now in COVID-19, which areas are going to be worst hit if there is another wave? It's not if, when there is another wave. Obviously, areas with low seroprevalence and areas with low vaccination coverage. So if you were to put vaccination coverage and seroprevalence into 2 table, both showing low and high, the areas with low vaccination coverage and low seroprevalence will be the worst hit. Why? Because most people are susceptible and therefore they will get the infection at a higher rate. And because there is no protective effect, they'll also end up in hospitalization and higher risk of mortality. But have we identified these areas locally at the district level or at the state level? If not, how are we well prepared for the next wave compared to the earlier 2 waves? It's simply not. You're waiting for a bouncer to come and then you would want to duck only when it is above your head. So this is not the way to tackle pandemics or any multiple waves. The lesson that we need to learn is one, build the capacity at the district, and two, make them strong enough to use the capacity there. So we have public health facilities spread across the nation. Sentinel Sero Survey is something that can be easily done. We have done that and shown, thanks to Professor Ravi's leadership and insisting the government to do this. We have done 2 rounds, and those results from the Sentinel Sero Survey have been used for testing strategy. For example, districts with a very high case to infection ratio, we know that there is a problem there testing, and therefore those districts have got better testing infrastructure. So evidence-based, we can all keep saying that this is very important, but to implement, we have to make those changes in the field. The second aspect is most of the solutions we think we know when we manage the program or read papers or understand from international perspective. But in terms of practicality, the field worker would know much more than the people who are planning it either at the state or national level. So there has to be a dialogue, there has to be a feedback mechanism of how to improve vaccination coverage. All my friends and seniors on the panel, they have worked in National Polio Surveillance Project in some way or the other. The strength of implementing polio eradication was micro-planning. The strength was mobilization campaigns. Do we see that happening? Fantastic effort that we have COVIN. I think that is a very good addition. But then when we have a new element added to the program, can we afford to forget the strengths of our existing vaccination program, which is micro-planning and mobilization? So with these 3 important points, one is contextually specific evidence-based approach at the district level. 2, institutionalized seroprevalence and assessing vulnerability to make sure that we are better prepared and tackle the next wave. 3, let us make a resolve to strengthen micro-planning and mobilization. Thank you.
Thank you so much, Dr. Babu. You have hit the nail on the head. One is we need to look at not top down but bottom up. And you gave a very good example of micro planning for polio eradication. I will take you even earlier than NPSP. In Universal Immunization Program, which I joined as an immunization officer in 1988, microplan started there. And the microplan guidelines did not go from the center. They were prepared at local level. I still keep a copy of what was done. This is Tikakaran Karyakram Margdarshika, developed by the grassroots level workers, and they don't have sophisticated technology. I am taking you back to late 80s. How do they draw map and every household on the map at sub-center level. Not only the beneficiaries on this map, but also social mobilizers. For every child, one or more social mobilizers who will help in getting that child vaccinated if there is a delay or if there is a resistance. Vaccine hesitancy can be addressed only at that level. 100% immunization can be only given at that level. Somehow that has been missed so far in this campaign. We need to build on that experience and keep looking at vulnerability so that you are not reactive, you are proactive in addressing the pandemic. Thank you so much, Dr. Giridhar. And you named the only woman on this panel. So I will now go to Dr. Farzana Islam for her insight into what have we seen the gaps as an academician, as a researcher, and what is your suggestion for, we are not still through the pandemic, so we can still learn from that and then look at the way forward. Over to you, Dr. Farzana.
Good afternoon, everyone. Thank you so much, Sanjeev sir, for this opportunity, and a very good afternoon. Sir, I'll be little bit giving a brief overview from the implementation side, from the service delivery side, because we also run the COVID vaccination center, and our department is in charge of that. So when it started with the free vaccination with the health in the first, second, third, fourth, and fourth phases. So initially, sir, as sir has also mentioned, previously, there were lots of COVID glitches. So it was not very easy from the service delivery part to manage those glitches, because though there were training and everything was in place, but it was very when the initial first 2 days, initial 1 week, we had to face lots of problem with the COVID app and everything. And then it started with successfully. We started with the healthcare worker phase of vaccination, but very surprisingly, as the senior people from the colleges has volunteered and they have got their first jab and everything. But very surprisingly, among all the healthcare workers, our nursing staff had lots of vaccine hesitancy. Hardly 10 to 20% of nursing, even till now, hardly it is. They have even the nursing superintendent and everything, they were not ready, and there were lots of hesitancy among them, and mainly among the young nurses. And second, people who had the hesitancy, and we actually had to motivate them a lot, are the medical students. So they were very much hesitant in getting the vaccine, but slowly we could able to motivate them, and we could make them take the vaccines. But even till now, the coverage among the students and among the nursing staff are quite low, and there is a fear of infertility somehow, as though our institute is mainly a minority institute, but we have seen among the Muslim nurses, the fear of infertility and everything was going up very much, and for that the hesitancy was much. And secondly, so when we have seen even also some fear of side effects among the students. And we have also, till now, we have vaccinated more than 10,000 people in our institute alone. And we have done a little bit of calculation analysis that when we talk about the side effects and everything, we have seen the younger group, age group, were suffering a lot. And that was also one of the main reasons, only the fever and tenderness and whatever it is, it was more among the young, in the 20s, among the students, at that age group. So that was also one of the reasons. Regarding other gaps in the vaccine implementation, when it started with the free vaccination, the response was very good, and the beneficiaries were eager, in both, when we started with the general population as well. But when as a private vaccination provider, we had faced lots of problems when the price, when it was capped till 250, it was still the beneficiaries were very much willing and they were coming and they were taking the vaccines. But now when it has gone up, and now at present we are giving Covaxin. We started with Covishield. Now we are restricted to Covaxin, and again, as the beneficiaries like rate has gone up. So all the private vaccination centers are facing these problems, because initially it was difficult for us to get the vaccines from the manufacturer directly. Now this has been settled down, but at the same time, getting the beneficiaries, because what happens, the private vaccination centers have bought all the vaccines, but getting the beneficiaries and previously, if I say, like when we in the initial months, we vaccinated more than 250 per day, but now it has gone down to 40-50 beneficiaries per day. So that is also one of the gap of price capping, because it is available freely in the government sector, and in the private sector it is much high. So this is also one of the main important gap what we faced. And regarding other issues, that is still, like if we talk about the second wave and protection about the vaccine in the disease, we have seen in our institute, yes, those who were affected in the first phase, and even also those who have got the jabs, they were less affected, less infected in the second wave, and it has really made a difference among all the who has taken the vaccines. So this is in short our experience over the how to, from the service delivery point of view.
Thank you so much, Dr. Farzana. We'll come back to you. You have highlighted the experience of a person who has been running a vaccination center, and what were the issues you faced, and what were the side effects which were seen in the population you were covering, and the transition from free vaccination to privatized vaccination, where people have to come and pay for the vaccine, and the problems you are facing, the number of cases, a number of people turning for vaccination has been adversely impacted, and government should have done something so that you are continuing to give vaccination to the full capacity. Thank you so much. We'll come back to you later. Sure. With that, can I move on to Dr. Raj Shankar Ghosh? Dr. Ghosh, over to you with your wide experience on immunization from grassroots level to the national policy and international organization level.
Thank you, sir.
Over to you.
First of all, I'd really like to thank the organizers and to you, sir, for inviting me to this discussion. And as Dr. Giridhar Babu said, we are thankful that it's a panel and not a manel. And thank you, Dr. Farzana, for joining us.
And thanks, Raj, for pushing us into that.
No, sir, thank you, sir. It is something I'm sure all of us wanted to have.
Yes, yes.
So, I think, before I begin, I just wanted to give a very broad overview of where we are in terms of the COVID vaccination in India today. So, as of yesterday, this is the report that I got today morning, we have around 576 million people who have been vaccinated. We have 48% of our eligible population, which means the 18 plus, vaccinated with at least one dose of the vaccine. 33% of the entire country's population of 1.3 billion have at least received one dose of the vaccine today. In terms of the full immunization, 14% of the eligible, which is the 18 plus again, have received the 2 doses of vaccines, and 9% of the entire country have received 2 doses, if I look at it in terms of the 1.3 billion. We started with our frontline workers. 75% of them have been fully vaccinated. Of our healthcare workers, 79% have been fully vaccinated. The picture in the 60 plus, which have been prioritized, is dismal. 30% have been fully vaccinated. If we look at the public health principles, and this is not about India, public health principles of immunization globally, we say, almost in a very funny way, that it rests on a SAD platform. The SAD platform is an acronym of supply, access, demand. And these are all interrelated. If we don't have a good supply, we will not have a good access. And if we don't have good access, we will not have a good demand. And if there is no good demand, again, the whole cycle is repeated. In case of COVID vaccination, India started with an advantage, with a huge advantage. The advantage we called in our circle as a mice advantage. What is the mice advantage? The first is the manufacturing capacity all of us have been talking about. India is one of the powerhouses of vaccine supply globally. Manufacturing, the Serum Institute, Bharat Biotech, the BioVs, and all of those. The second of mice is the I. It is innovation. India has done technological and social innovations for immunization through its polio program, through its Mission Indradhanush, intensified Mission Indradhanush from the smallpox days. And India's innovation is an unique driver of its program. The third is the C. And I really wanted to congratulate Dr. Babu because he brought up this issue about the polio program. And I do want to lay a lot of stress on the commitment of our health workers, frontline workers, of the program managers, of the bureaucracy, and I will say also at the political level in terms of really battling COVID-19. The commitment should always be kept in mind as one of our drivers of the program. And particularly here, I'm talking of the health workers who really take all the steps to ensure that vaccines reach. And in terms of the last E is what we are talking about, our efficiency and experience of conducting large campaigns, from Mission Indradhanush to Pulse Polio campaigns to intensified Mission Indradhanush, all of these. So therefore, we had an advantage. We heard from Dr. Babu about the COVID, which was a huge kind of innovation that brought the access closer to people, but there was a digital divide. Now, every innovation, when it is brought, like a new vaccine, has its own challenges. What was good in the COVID program that happened? That we found one of the best technological brains within the country and who had one of the largest experience of running the Aadhaar campaign in India, Mr. Arish Sharma, who really headed this committee and almost looked at day-to-day challenges that COVID faced. And I will give a lot of credit to our implementing partners, the Immunization Division, the UNDP, who also worked very closely in order to address almost challenges day-to-day. It was like, the Immunization Technical Support Unit was raising the problem with the ministry about people not being able to access the COVID, and there was a solution within 2 days. That, well, we will now kind of develop a system where there will be walk-ins and there will be assisted registration. So this kind of mitigation of the problem was something which was unique. We had earlier seen innovations which, were applied. There was a pilot, then there was a scale-up, which we saw in case of even Electronic Vaccine Intelligence Network. But in case of COVID, it was almost happening on a day-to-day basis. This was unique. The next point that I want to really harp upon is what Dr. Madan Gopal said, that there are vaccines in the pipeline now. We do not know about the availability of Moderna, and very frankly, I personally don't rely a lot on Moderna vaccine to become one of the main vaccines to be in our COVID vaccination program because of the price, because of the cold chain issues, because of the supply issues, and globally we have faced all of this problem. And there is no beating around the bush that the world could have done much better through its global platforms in terms of ensuring that there is better supply of vaccines to countries where, in Africa, in South Asia, in other places where they really needed the vaccine in order to overcome this problem. That has not happened. Let us restrict to India. But in India, we saw that the kind of approvals that happened, I would say, I think Dr. Ravi brought this up about dialogue around where there needed to be more transparency. We could have heard the scientists better. we could have had a better transparent dialogue. We could have had a better communication, not only with the scientific community, but with the larger community. Because look at the larger community. Every day, they were reading newspapers where there were reports from across the world of various adverse events. There was a complete silence around adverse events happening within the country from vaccines. And it was as if, there was nothing happening. But slowly, due to probably better conversation, better understanding, the adverse events were being reported. And we now have on the ministry website adverse events being reported. But what I wanted to really harp upon is that the confidence of the public and the confidence of the scientific community is critical. We need to have a more transparent dialogue. In fact, what we say is, in case of public health, there is a very straightforward key pathway. We call it transparency, trust, tikakaran. If we don't have transparency, we will not have the trust of the scientific community and the larger community, and tikakaran will not happen to the extent we want it to happen. Therefore, I would really say that we are in a very good position. The utilization of whatever vaccine is available is good. We need to ramp up our vaccine supply. We need to ensure that we have more vaccines in order to reach out to a larger population. The second is, as Dr. Ravi mentioned, the scientific issues that we need to look at, the booster doses, the issues about mix and match, those need to be thoroughly studied by the Indian Council of Medical Research with other partners. The third is that we need to have a transparent kind of sharing of information with the community, both scientific and the larger community. And fourth is we need to keep on ensuring that there is a very strong surveillance to detect any transmission that is happening and also to detect any adverse event that is happening. With this, I think we will be doing a very good program. And inshallah, I am very optimistic that with the larger pool of vaccines, we will be able to achieve a very good coverage by the first or second quarter of next year. Thank you, sir.
Thank you so much, Dr. Ghosh. You have given a perfect summary of the issues we faced, the principles of supply, access, and demand in any immunization program needs to be kept in mind. And I agree with you, we have more capacity to vaccinate the population in India than the vaccine available, and there is a sense of urgency to produce or bring in more vaccine so that we can vaccinate more and more people. And as I mentioned earlier, I joined as an immunization officer in 1988. And what I learned from my experience, Dr. Ghosh, is every dose is important. You do not look at the dose by the price of it. You look at how many lives it is going to save. Absolutely. And how much misery. So cost is immaterial. Absolutely. You have India is underspending on health. They can spend more on vaccine. Absolutely. And learning from this experience, as we learned from polio and other campaigns, we can now roll out vaccination of adult population. Very important points, and we will continue to learn. Very good example. We learned as we went, but we need more transparency so that we, the scientific community, program managers have more faith in the system, and the people have more trust in the system. Very important points raised by you. And you talked of the end game success, and I will now turn over to the author of this book, Till We Win, so that he can give us insight. And those of you who have not read, I am referring to the audience, please read this book. This book is not only just on COVID. This gives you a good insight into historical perspective of pandemics over last 5,000 years and what we have learned. Some of the interventions like hand washing, how it started, and the person who started hand washing, Dr. Laharia has given that story, how he was sidelined by the scientific community practitioners of modern medicine when he said, you must wash your hands before you touch the patient. So with that, I will hand it over to Dr. Chandrakant Laharia, who can give us more insight into the gaps He has written a book already, many articles on this aspect. I'm sure it will be very valuable for us to listen to him. Over to you, Dr. Chandrakant Laharia.
Thank you very much, Professor Dr. Sanjeev Kumar, for kind words. It's really challenging to speak when such an eminent panel has already said everything which need to be said. So in this context, we already know some of the challenges in the vaccination program. We also know that India has done a really wonderful job of administering 560 million shots of vaccine. So that's a really big achievement. Many achievements, many challenges, and this has been discussed in last nearly 7.5 months or so. Now, it depends upon that what is the purpose of any discussion or discourse. And since many things have been discussed, so I would like to flag a few. One is that we need to acknowledge and recognize that India has done a wonderful job, but we also need to be self-critical so we can improve. But sometimes it appears that the dialogue happens in isolation, like either we are too optimistic or too pessimistic. The challenge is that sometimes the individuals or experts who understand the topic, they do not speak to the authorities who are involved in this thing. For whatever reason, that whether they might get offended or not, or we feel compelled to say a few things which are really positive, and then positive are picked and negatives are never taken care of. One of the biggest thing which should happen from this COVID-19 pandemic and this learning is that we should derive lessons. And I am really concerned that while we are doing definitely a good job, nearly half of the adult population, 48% of adult target population has received at least one shot. That's a big feat. But we should not stop there. We should remember that whatever the challenges were there, those lessons are derived and learned, and in future we avoid to repeat them. So there are a few things which I would like to reflect, which have not been covered. One is that India tried a very good experiment of engaging private sector by allocating 25% of the vaccine shots. But it took nearly 3 months before a country could say that private sector vaccination is not up to the mark and not administering 25%. And what happened in that 3 month period? That a lot of vaccine was blocked, so private sector has uninterrupted supply of vaccines, which was like people who go to private sector would never be denied vaccine, while public sector facilities had a temporary dry days for vaccines, like many of those were closed. And it was only on 3rd August, after the first wave, when the decision was made, that India said that, okay, we need not to earmark 25% or quarter of vaccines for private sector. And this was happening in spite of that, like this was, the issue was flagged that private sector always had 10 to 15% of the total vaccines in universal immunization program, total vaccination in universal immunization program. Also in COVID-19, the proportion of private sector vaccination facilities was around 3 to 5%. So 3 to 5% of vaccination centers had a 25% vaccine. So those are the kind of gross policies which could have been avoided, and we should take lessons from it. If it's good idea that private sector should be engaged, rather India has a 70% of the curative services coming from private sector. But we also need to remember the preventive or promotive services, government facilities are the core. If 25% were being allocated, we need to be mindful that how that coverage, that vaccination can be stepped up. Some additional steps should have been done. So that's the one part. What happened with this kind of, and this is just one example, and what happened with that kind of policy, it introduced by the government intervention the inequities. It resulted that private sector, since it's in urban area, private sector can be afforded by rich people. So only the rich people who can afford had a far higher access, easy access. They could have opted for government facility and private facility and got vaccinated. And the limited supply was not available for public or government facility. That's the one. So inequities in the terms of rich, poor, inequities in terms of urban population, because private facilities are in urban setting and rather toward the major cities or metropolitan cities. So inequities have been introduced. Though there have been symbolic interventions to near home COVID vaccination centers, but much of those interventions were not helpful. Similarly, I think India should have done more closer to the facility mobile van-based COVID-19 vaccination, which is not being done with all of those challenges. So what we should be looking forward, I believe that over a period of time, we have seen that availability of COVID-19 vaccines has always been, even till now, far below than the projections. And now that's availability, let it be. We need to be optimally use those vaccines. So we means like government at the national and state level need to be optimally using that amount of vaccine in a targeted fashion. So there had to be a rethinking on distribution of the vaccine available to those settings where transmission is high. For example, Kerala, Maharashtra, or even northeastern states. That's one approach. So we need to be really dynamic in this process, and that I don't foresee happening. Then within the state, there is no point in state government crying that we have a less vaccine, because that's a vaccine which is available. So even state has a responsibility to distribute or target the available vaccine with them to those districts where there is a maximum need. So that those kind of targeted intervention need to be done. Another point is that there has to be specific focus on addressing inequities, and this CoWIN is really wonderful platform. It shows the potential. It can, through that application, if we go into to the back data, and then we can always find out which are the population which are being left behind. But that is not happening. So the population or the segregated data from CoWIN is not available, which will be really easy. That can be easily utilized to identify inequities and targeted vaccination. So that CoWIN platform can be better utilized for addressing inequities. Final part is that while we are really confident that India will do a good job, but we also need to remember that there would be vaccine hesitancy at some point of time, and there had to be concerted effort for a future scenario somewhere around mid-October, when there would be more vaccine supply but less demand. And even that point of time, there would be people who would be unvaccinated. So we should be preparing for that. And last 1 minute I would spend on two aspects. One is that yesterday Indian government or drug regulator in India approved one vaccine for 12 to 17 years. But I think this is kind of generating a lot of interest, and people would say that, okay, let's start vaccination for children or older children 12 to 17 years. But in my opinion, licensing or availability of vaccine should not translate into that children should be vaccinated because there is a vaccine license for that age group. That should be a really considered decision by the expert groups, not by pressure by public opinion. In many countries, United Kingdom and other countries, have a COVID-19 vaccines which are licensed and sufficient supply for 12 to 17 years. Even then, they have not started. So a decision to vaccinate 12 to 17 years should be based upon scientific evidence, not merely because vaccines have been licensed. And final part is a booster shot is not required. Previous speaker have spoken about it. There is not enough evidence. The first priority has to be vaccine, providing at least single shot to majority of the population, a large chunk of population, before going for booster shot. But similar approach need to be followed, which is science evidence-based approach rather than going what other countries are doing. Thank you very much. Dr. Sanjeev Kumar, you are mute.
Thanks. You have really brought out evidence-based points on how do we allocate vaccine, not just based on quota, but based on actual utilization of vaccine. That's what we have been doing in all our immunization programs. You know, you keep pushing vaccines and nobody is using at a particular facility when the other facilities are suffering from shortage of vaccine. Another important aspect is contribution to inequity. There is a global inequity between countries which are producing vaccines and countries which are not producing vaccine. And there is also inequity when you start giving to private sector healthcare delivery institutions, which are predominantly in urban areas. And the last point you made is very, very important. Let us not vaccinate population only because of publicity. Let us vaccinate population based on evidence. And the evidence today is the age group of second decade of life, 10 to 20, less than 20, has the lowest risk of infection and also has the lowest morbidity and mortality if they get infection. So it needs to be done based on the evidence and not at the cost of population which is at higher risk of falling sick and also at higher risk of having fatal outcome if they get infected. I am told we are more than 10 minutes over the time. So I will not go to each one of you, but if any one of you wants to make the last comment before we close the discussion, any one of you, I will not suggest that every one of you speak, but anyone. Dr. Ravi, you want to say anything?
No, I am absolutely fine.
Okay, Dr. Ghosh?
So, yeah, if I'm permitted, I think I'll just say
Please.
One thing that, when we started working, as you said, sir, about 30 years back when I started working, one of the first things my teacher told me was that we need to be very efficient. That was the first E I learned. Then, working in the polio program, we learned about the issues of equity, evidence, or all these different Ps we learned. The Mission Indradhanush and the routine immunization program taught us about empowerment of the community. One of the things that COVID has taught us, and I really tell everyone that I meet, that we need to keep this E in mind, which is empathy, that we really need to make our policies and programs keeping the population in mind, which actually Dr. Laharia just now raised, that the population must get the vaccine, the equity issues and all of that, and equity across gender, across geography, across the issues of the geopolitics that you mentioned, that some nations have, some nations do not have. These need to be kept in mind. So empathy is one very important lesson from our COVID debacle that we have had, and we must keep that in mind. So therefore, I just wanted to say that I really enjoyed this conversation very much today.
Thank you, Dr. Ghosh. Dr. Farzana, you have the last word.
Thank you. Just first of all, I'd like to thank everyone for giving me this opportunity this afternoon. And only I just want to emphasize on one important issue. What we have seen that Dr. Laharia also mentioned that vaccine hesitancy, because it is coming up in in the first wave. After the first wave, it was there, but again after the second wave, it was not so much. But again, we are seeing that people are not coming for vaccination, though people are we are covering with so much of doses and everything, but vaccine hesitancy is still there, and we have to we have to look into that also as well.
Thank you, Dr. Farzana. Dr. Babu, you want to say something?
No, sir. Thank you. No, thank you.
Okay. Thanks to all of you, and thanks to the organizers for getting the best people available in the country to speak in this session, and to all of you for sparing time to be part of this panel and contributing to the discussion. And I'm sure there are many lessons on way forward. I want to end with one statement. We looked at many good things, but what Prime Minister Narendra Modi said when talking to the Olympic team, which when they came back to India and met him, "Jeet ko sar par chadhne mat do." We have done very well in certain areas, but we need to do better. जीत को सर पर चढ़ने मत दो, हार को मन में बसने मत दो. Yes, there were many things we went wrong. We need to learn from those and continue to do better and better and better with every day. That's how public health is. Thank you so much. Nalini Kaushik is already there to take us through the next session. Thank you so much, each one of you. It has been a pleasure moderating the discussion and listening to your expert inputs. Thank you so much.
Thank you.
Over to you, Nalini.
Thank you, Dr. Sanjeev, and thank you to all our panelists for giving us this insightful session. And I think it won't be wrong to say that we had some of the most senior and the most experienced stakeholders on our previous panel from if I look at the immunization ecosystem of our country here. And in fact, it was a privilege today to hear from all of you. And, personally also, having worked with many of you, it's been a privilege. And this is exactly the conversation that we needed sort of to, begin with. Because as Dr. Sanjeev said, that we have had a lot of successes, but let us not stop there. And the needle has to keep moving by assessing and relearning, from the positives and also from the failures. So thank you so much to all of you. And taking the same conversation ahead, we move on to our next panel, which is titled as Preventive Strategy Against Non-Communicable Diseases Through Timely Vaccination. So in this particular panel, the idea is essentially to, look at the relationship between vaccination and the growing burden of non-communicable diseases. So as we all know that, vaccines, they represent one of the most and the greatest achievements of medicines. They are known to dramatically reduce the incidence of serious life-threatening infectious diseases. And, of course, they allow people to live a longer and healthier life. We have seen, many vaccines have been created, against life-threatening infectious diseases. And in the previous panel also, we saw that, the experts brainstormed on, the polio immunization program that we had in India, and measles. And recently we have seen the same, in the case of COVID-19. However, as the burden of non-communicable diseases is also, increasing not only in India, but also globally, it accounts for 63% of all global deaths. And therefore, new therapies and therapeutic approaches are being investigated, and vaccines comprise one of the, biggest component there. Also, furthermore, the economic and the social losses which happen due to non-communicable diseases are not inevitable. And options does exist, for actions that even policymakers, in today's time are, brainstorming upon and form certain programs that are aimed from prevention to early detection, treatment, and care. And to contextualize the same today, in the Indian framework and reflect upon the issues that we are discussing today, we have with us 3 experts who work on different dimensions of the same spectrum that aims to bring innovative health solutions to lessen the ever-increasing burden in India. And I would like to start by welcoming our distinguished panelists today. So we have with us Professor A.B. Day, who is the consultant of healthy aging with the World Health Organization. And he's also the former head at the Department of Geriatric Medicine, AIIMS, New Delhi. Dr. Mohammad Ami, who is the head of primary healthcare technology and innovations at PATH. And also we have with us Dr. Rishikesh Pai, who is the medical director at Bloom IVF and President-elect FOGSAI. A warm welcome to all of you, and many thanks for sparing your precious time to be here with us and having this discussion. Many thanks to all of you. And so beginning my conversation today, I would like to start with Dr. Day, with you, that in today's discussion, we had one panel on the childhood immunization programs and the successes that we have had in India in last 5 or 6 decades. And then we also, we had one session dedicated specifically, on the recent experience of COVID that we had. But in this particular session, if we want to contextualize non-communicable diseases and the interrelationship between the vaccination. So if you could just simplify, the role of vaccines, specifically the adult vaccination, and its likely impact on the healthcare, overall health systems, and maybe also in the context of Indian health systems. So if you could just, begin with setting the context for us today. Over to you, sir. Sir, you are on mute. Could you please unmute yourself? Thank you.
Good afternoon, everybody, and I thank the organizers for having me here and talk on a topic which is rather contradictory with in the heading is itself vaccine and non-communicable disease. So I was just wondering how I relate to them, and as a medical teacher of many decades, you have to make some story or the other. So I'll try to make some story and try to justify my presence here. I have been in the medical system for about 5 decades. Seeing 2 diseases eradicated with vaccination program. Smallpox when I was a final year student, the last patient was detected in Bihar, and then we had polio eradication the earlier part of the century. And then while we were feeling happy, and my employers, World Health Organization, told the whole world that infectious diseases or communicable diseases are gone, and then don't bother about them. We had a small spurt of HIV/AIDS, which told us that, don't be so smart. We are still there. Viruses, bacteria are still there, and they will be there. And the Americans and the Europeans got the drugs for it, and now nobody talks about HIV/AIDS as a topic of discussion in any of our medical discourses nowadays. In 1990s and 2000, 50% of time will go to HIV/AIDS. And we were feeling happy, and then the COVID came in and told, hold on, the smaller the size of the organism, difficult it is to control it. So we now are convinced that we'll learn to live with communicable diseases of various kinds, which may or may not be treatable, or may or may not be preventable by vaccines. And it's quite I always take it as a positive outcome of COVID pandemic, that we had a vaccine created in less than a year's time. And in the previous session, it was told that more than 56 crore shots, or 560 million shots have been given. So it's a achievement of science that how fast we can get a curative drug. And so in the whole scenario of glory of vaccines and the onslaught of infectious disease, where our non-communicable disease stand. For last 20 years, we were told by my employer, World Health Organization, that by 2020, 80-90% of deaths will be because of non-communicable diseases and trauma, road accident, and very little infectious disease. And with our undergraduate education, at least my undergraduate education, totally embedded in infectious disease and making exciting diagnosis with one infection and trying to explain everything. And then we found that NCDs are the flavor of the season at this point of time, till about 2 years back, and all our work towards NCDs. NCDs and vaccination, there are always a conflict of interest as to how do the vaccine part comes into NCD program. There are two ways of looking at it, that pure vaccine for NCDs, which are, say, chronic diseases like, say, multiple sclerosis, psoriasis, etc., whether they are vaccines or they are biologicals, that is still debated, and how do we popularize them, or how we cost them. They're extremely costly, safety not yet assured, especially we knew that in Alzheimer's disease, the vaccine did not work. So we are not getting into vaccines for NCDs. We are probably more comfortable when we look at the NCD population, that is the older population, in which whom I treat as, which is my expertise or inability, you can say, that the older population need vaccine. They need vaccine because they have got a huge load of NCDs. We have seen that people who have got, say, chronic heart failure and chronic bronchitis, diabetes, kidney disease, liver disease, they are the right candidates to get the vaccines. And simple vaccines. Just address respiratory infection. Many of the crises in the healthcare system will be addressed. That is with pneumococcal vaccine and with influenza vaccine. Premature deaths will be prevented, and hospitalization, entry to ICU with severe pneumonia. And all this can be addressed to some extent. They may not be life-saving, but at least they will make the disease part more manageable and more acceptable to the health system. And then we found that there are some conditions which are not so life-threatening, but painful diseases, say herpes zoster vaccine. And we are told that most adults in our country do harbor the virus from their childhood chicken pox, and at some unfortunate moment the virus can get activated and give a painful condition. We have reported in last few years quite a few times tetanus in older people, which is very unusual to consider that how can older people get tetanus when they have received all the vaccines that are one of the easiest disease to control is tetanus. But do understand that universal vaccination started in early 60s when my clients were already become adolescent and adults, and so they never had the opportunity to get their vaccine. So we do often see once in 5 years or so one difficult diagnosis, and finally you end up with the diagnosis tetanus. So where do we stand, NCD and vaccine? So I feel that popularizing vaccine for population above the age of 50 years of age, who are the carriers of most non-communicable diseases, it helps in preventing or kind of avoiding a small part of their misery by taking care of respiratory infection, pneumonia, pulmonary respiratory failure, entry to ICU, the cost of care, and the complications thereafter. So I stop here and leave it at that. Thank you.
Thank you, sir. And I think one thing that I capture from your the landscaping that you've done, yes, you feel that yes, the interrelationship between the non-communicable disease and vaccination could be a point of contention. However, a population, an elderly population above the age of 50, is still a critical population segment for us to be considered when we think of vaccination and the high risk groups here. Thank you, sir, on that, and I'll be coming back to you for the second round of questions. Dr. Amil, if I come to you for this particular point of discussion right now, that yes, so the relationship between the non-communicable diseases and the vaccination, yet yes, in the scientific community, the conversation is still sort of at its very early stages, but we have seen certain adult vaccinations such as so the hepatitis elimination program itself dwells a lot on the relevance of early diagnosis and vaccination preventive strategy per se. We have seen cervical vaccination entire conversation also globally and in the Indian context as well. So specifically if we look at yes, there is one arm of the NCD vaccinations which is still under development in the scientific community, where we have seen the scientific developments are at a very nascent stage. Yet there are certain developments that we have seen, and certain programs are really harboring at least prevention of cancer, etc. On certain vaccinations. So assessing that, what would be your take on in the context setting of adult vaccination when it comes to certain NCDs? Over to you, Dr. Remy.
Thanks, Nalini. I hope my voice is clear to all of you, because I'm not using earphone, the mouthpiece today.
Okay, no, that's perfectly fine. You're
so I'll be speaking more from our experience, what we are currently working in this area, and I hope that makes sense, because as Dr. Day said, it's somehow a bit difficult to make the relation between the two, but certainly there are areas that we would want to talk about, build upon our experiences in NCDs and vaccination. So at PATH, we've done a comprehensive landscaping study on NCDs and found that morbidity and mortality due to NCDs and injuries have increased in the past few years. And all of us know, whereas morbidity and mortality due to communicable maternal neonatal infections has declined. Now, the 5 leading chronic diseases in India: mental health, cardiovascular diseases, diabetes mellitus, chronic obstructive pulmonary diseases, and cancer. So the prevalence of NCDs is likely to increase in the coming years due to higher life expectancy, as well as factors such as urbanization and industrialization. So, number one, the major NCDs share common behavioral risks. So, for example, tobacco, unhealthy diet, physical inactivity, and harmful use of alcohol, and provide common pathways for prevention. Is one. Second, policies for prevention and control of non-communicable diseases need to address the unhealthy behaviors of people, including some of these which I mentioned. Then these behaviors are influenced by economic growth, globalization, and unplanned urbanization. It's also important that health education and counseling efforts of health professionals can improve health literacy and play an important role. However, changing behaviors of people is challenging and cannot be accomplished by healthcare alone. And that's where I said education plays an important role. So, an enabling policy environment is fundamental for sustaining healthy behavior. This requires health to be a key consideration of sector-wide public policies in domains such as transport, agriculture, education, finance, social services, and trade. And Dr. Sanjeev Kumar just left. He's been my boss in at NHSRC, and he used to talk a lot about health in all policies. And I think that's what I'm also alluding to. So only such a supportive policy environment of health and all policy can provide people opportunities and affordable choices to adopt healthy behavior in relation to diet, physical activity, tobacco, and all alcohol use and mental well-being. You mentioned about hepatitis B. So vaccination against hepatitis B has the potential to improve prevention of primary cancer of liver. Current high cost of vaccines prevent them from being widely applied in LMICs, in India especially. Even though these infections are responsible for a significant proportion of cancers. There is also some evidence that influenza vaccines reduces in COPD patients and the pneumococcal vaccines for patients with some chronic lung conditions and maybe beneficial. With this, maybe I'll pause here in the interest of time, but happy to talk more in case we have some more time on our work related in this area and also some of our recommendations that we have. But I'm not sure how much time I might have. Thanks.
Thank you, Dr. Ramil. Yes, of course. I will be coming at least for one round of insights from you. So moving on to Dr. Rishikesh, to you, that my same question, that yes, we might be at a very preliminary stage when it comes to delving a lot on a mature discussion on NCDs vis-a-vis vaccinations. However, there are certain groups where we do have vaccination. Like Dr. Amil just mentioned about influenza, and then there are cervical cancer vaccines and hepatitis. They all have access issues. All of them have also been grappled with their own, controversies and also some challenges on the regulatory front. So what would be your take, when we have to specifically assess, this entire movement towards conversations of adult vaccination, specifically in the context of NCDs in India?
Thank you for calling me here. Actually, I'm so, lucky, because being the president-elect of the Federation, before that I was Secretary General of the Federation, and we are one of the largest federations, second largest medical body and we really influence women's health in a big way. 2 years back, I was on the Abbott board. The Abbott had created a board of advocacy of vaccine. And, it's a learning process. So in that, we all got together and we had this concept of adult vaccination, which is, stimulated me a lot because, that can be applied. So now, if I look at the NCD, I was just looking at the internet because I was also wondering NCD and how to correlate it. But, so your program is a eye-opener for me. Every program. Just 2-3 days back, I was on a vaccine program where I got some more input. Today, just now in the evening, I'm giving a talk on influenza vaccine. So these are all because of my position, by grace of God. All these things that I do positively reinforce what I have a plan to do for our federation and for our women's programs in the future.
Right.
So now, the NCD, for example. So what in women's health, what are we looking at? So we are looking at certain diseases which not directly, so like smallpox and all, you get the infection. COVID virus, you get the infection and you die. You understand? So it's acute. So that's why it's communicable. So one can, classify that, okay, something that is not acute can be classified as NCD. So what is not acute in women, for example, rubella. Many of them are rubella negative. When they come to us for the pregnancy, rubella negative patients can be vaccinated to prevent congenital malformations in the pregnant women. Then all the other vaccines in the pregnant, diphtheria, pertussis, tetanus, as Dr. Dave said, all are indirectly protecting the pregnant women from getting disease. Then we have the influenza. Again, I'm giving a talk in the evening just now. After you go, I go giving a big talk in the Lucknow Society at 5:30 on influenza vaccination in pregnancy. Again, you are preventing not only the women, because pregnant women are vulnerable to influenza, and it's not directly that influenza will kill them or something, but there is a lot of complications that can be reduced. And in the first 6 months of after delivery, the child can't be vaccinated, so those antibodies and the vaccination of the pregnant women protects the child indirectly from that infection. And then we have the cancer. So we have the hepatitis B, which is a big thing, and a lot of funding has been given by the government. There's been a lot of discounting by the government, and it has been a fantastic program in our country. And then we also have the HPV vaccine, the human papilloma virus vaccine. 3 days back, I was fortunate to listen to two great WHO girls, Partha Das and one more person from the World Health Organization, and they were propounding how we can screen for HIV, the HIV test, not the pap smear, but the other test for the HPV test, which can be done. And they have shown definitively that by using the HPV test for screening and by tackling the cervical intrapleural neoplasias and those who are positive for the HPV test, screening them, that they have shown that that can reduce the incidence of cervical cancer and can also decrease the mortality. So I would leave this by opening gambit by saying that, when I look at it from the outside, I sometimes feel I should have been the health minister of the country. But okay, I'm not. So what can I do? So looking at it from the outside, I think that there's let's say there are three groups of people in our country. One group, which I would say is the lucky group, in a way, is the poor group, because the poor group is serviced by the health department of the state and the center, and they are getting their share in a way. Of course, they are poor, they are malnourished, they are the disadvantage of society, but the government over the last 70 years has slowly and surely progressed in a very effective way, and that group, without their knowledge, is getting a lot of services which the other group is not getting. The private group, for that matter, it's a free for all. Even so many, you will be surprised. My mother, who all of us are doctors in the family, she never had a pap smear in her life. Okay, so what I'm trying to say, the private sector, which is 300-400 million people, are on their own. Aya gaya Ram, no problem. Aya to kiya, nahi to nahi. Then we have an intersection section, which are not that well off, but they don't want to go to the general hospital. They are also disadvantaged. And then we have the general hospital section, which is standardized. They have got the proper data coming in. Everything is being done for them. The Asha workers are there. So that group, in fact, I always tell my patients who come in my private, I say, listen, because you are in a private, now you don't get the right care. Because the care has to be decided by you on your own. It is, what you get from internet. While the other group, that is a 50% group, which is disadvantaged, they are getting a standard proper care. The secretaries of health in the state and the central ministry, the implementation policy is going perfect. The data collection is also very good. So we have three Indias. In healthcare sector, we have three Indias. One is the lucky India, I call it, the lower group, which is getting everything proper. They are getting vaccinated. They are doing this. They are getting. Then the second group is the intersection group. They are in the limbo, gray zone area. And because they want to go to the public hospital, but they say, "Arey, kitna kharab hai, hum kaise jayenge, hum kaise line mein khade rahenge." and then we have the private group, which is on a free-for-all basis. So we have to integrate this three India.
Right.
That is the tragedy of this country. Total disintegration is there. Integration. This is going to be my slogan. Integration of thought, integration of processes, integration. If someone says about vaccine, someone talks about diabetes, someone talks about hypertension, someone talks about anemia. Why can't we do it in one shot? One shot. Data collection, one shot. Integration, one shot. Advocacy, one shot. Implementation, one shot. That is what we need. Then everything will get solved very easily.
Right. Absolutely. Thank you so much, Dr. Rishikesh. And I think you very nicely and appropriately, I think, set the entire context of what really we wanted to, initiate the conversation towards. Because and I think the examples you gave, first of all, rubella vaccine, influenza, hepatitis, cervical vaccine. Yes, if we look at the larger context of non-communicable diseases, maybe the conversation appears a little bit, premature. But when we look at, the individualized focus, that's where the eye opener, the thing lies for us. And like you said about, about pap smear, an example from your home itself, that, awareness is like a key gap when it comes to, accessing. And I think in just the previous session, Dr. Ghosh from BMJF mentioned, public health principles and 3 critical aspects, of public health principles, the SAD model that we say, supply, access, and demand. Until the time, I think all of that doesn't, is contextualized in an integrated manner. That's where, we end up failing, even if we have the demand and there's no supply, and vice versa.
One more thing before I would like to interject. I feel that there's an internal drive that is also lacking, and that is because we don't catch them young. Right. You understand? We have to. Right. So, like yesterday, I was listening. It's a totally tangent thought. Yesterday, I was listening to Amish, who has written a lot of books, and he said one of the important things of Ayurveda is that they teach you to do healthy living. The modern medicine more of tackling emergency care, no doubt surgical. That is modern medicine good, but what Ayurveda teaches us is wellness.
Underlying,
the wellness part which is there, that is vaccine also. Vaccine is a part of that preventive overall modality, and that wellness has to be taught to our children.
Absolutely.
When you're in school, you have to be taught that wellness. When you're in school, if you are given food which is less of sugar and salt, then you will not eat sugar and salt when you're older. You need to get used to it. So we need to catch them young. My mother didn't do it because she didn't have the internal drive of preventive care, because she was never exposed to it. So that exposure is very important, and from the beginning of life.
Right. Absolutely, sir. And I think the idea of wellness that you mentioned, I think it is one of the key central and an integral component of the concept of tackling NCDs altogether, because as we see that most of it is also a lifestyle component, which results into, the higher incidence of NCDs. And I think that's where the entire concept of wellness comes into play. Thank you, sir. And I think, again, going back to the concept of, SAD, supply, access, and demand. And Dr. Day, I would like to hear from you there that, now we have, in case of influenza, what we saw during even, at the time of COVID vaccination, there were influenza-like illnesses, etc., where the government of India had to revise the guidelines, and they specifically created a high-risk category for pregnant women, people who are diabetic, etc., and healthcare professionals who need to be mandatorily, immunized for influenza. This is at a programmatic level. Again, how do we bridge the gap of supply, access, and demand? Because what we get stuck here is the conversations many a times about access. We have modalities available, either the cost is high or there is lack of awareness. That's where we sort of bring in the gaps at the systems delivery level. So how do you see that, in the context of immunization in India?
If I'll give the example of influenza vaccination, as you raised the issue. The cost is an important factor. Influenza vaccine is costly. So if you think that, if we consider that influenza vaccination gets into some kind of a government sponsored program, then this has to be done every year. So if we look at the logistics of giving vaccine every year to a large population in the context of COVID-19 vaccination program, it's difficult. So obviously we have to kind of prioritize as to who needs it most and where it is effective or will be cost effective and doable also. In many of the North America as well as in Europe, influenza vaccination is a free program which is driven by the government, and also the professional association support it. Still then, with all this drive available freely in public places, because influenza vaccine doesn't require any supervision for a longer period of time, it's a very safe vaccine. Still we have a problem of not more than 40 to 50% of these privileged populations are vaccinated.
Right.
So that means there is no desire to get vaccinated for influenza. So even further restrictions, further prioritization have come in that all those who are in long-term care institutions, their caregivers in the institution from formal or informal care sector probably need it the most. In India, we tried out, I tried to get influenza vaccine and pneumococcal vaccine into a national program for healthcare of the elderly in 2014 for 75 plus age group in some of my meetings in the ministry. It worked out, but then we found that there are no takers from the health system. So for example, in my previous employment as the head of geriatric medicine at AIMS, we used to spend a lot of money in procuring influenza vaccine, pneumococcal vaccine, and then that will be my headache to see that they are all administered to older patients who are coming to us in large numbers, because the residents will all never consider that this is one of the preventive program, like seeing BP, I must also get the vaccination done.
Right.
So access is a problem, and also the health professionals desire to use it in large number of older people, especially those who are vulnerable to complications of, for example, those who have got COPD or heart failure, or those who have cancer or chronic liver disease or chronic kidney disease, who are the likely candidates to get influenza because of visiting health systems or getting exposed to other population and get into complications. So access is a problem, awareness among the doctors and health professionals is a problem, and awareness in the general public is also a problem. So there are triple issues here. So how we address this? Probably meetings like this will provide some solution to the problem as to bring down the cost, but here cost is not the major issue. The issue is desire to get the injection, the doctor knowing that, okay, I have got a chance encounter with this older person with heart failure, should I not give the vaccine, influenza and pneumococcal vaccine? So I see this as a major crisis of logistics rather than the cost of the vaccine or access to vaccine.
Right, sir, right. Absolutely, yeah. Thank you, sir. And I think, yes, I think it's access, as much as it is dependent upon the infrastructure, it is equally dependent on various other factors, and where, like you pointed that, here the role of HCPs, the healthcare profession, how that really also is very critical in driving access besides the conversations about cost, etc. Dr. Amil, if I come to you with the same question, like Dr. Day has contextualized the whole, the idea of infrastructure and, other access in the context of infrastructure development. But there's always a specific need of capacity and infrastructure, when we talk about, smooth, not just implementation, but also how do you normalize the entire conversation of vaccination? Because how we saw that in such a, diversified country like India, hesitation and behavior, it plays a huge role in people's acceptance of, certain new programs, like, how we saw similarly, I think in all vaccination, drives that we have seen, either for cervical vaccination or influenza, somewhere the problem lies at the level of, it's healthcare professionals, but maybe also at the level of the takers, where people are really need to be sensitized about, normalizing their behavior around vaccination. So given our diversity, also it won't be wrong to say that we need many more innovative, models of service delivery. And you've been at the interface of, the diagnostic sides of, the world, and then, now also, dealing with the primary care and the innovative solutions. So what would you say that, when we think of, sustainable approaches when it comes to normalizing our behavior towards, vaccination and the related programs?
Thanks, Nalini, for your question. In fact, I'll take a step back and we'll talk a bit more comprehensive and with a more holistic approach. So what we recommend is that strengthen the NCD component of universal health coverage through health and wellness centers. As you requested to talk on the primary health centers and health and wellness centers is going to be very, very important. And here, integration of digital health services, electronic health records, and speedy implementation of the National Health ID is going to play an important role in terms of technology and innovations that you specifically asked for. Then design holistic interventions that involve upgrading infrastructure, deploying more efficient supply chain systems like Dr. Day mentioned, especially for drugs and diagnostics, and designing and building an adequate referral mechanisms to the appropriate level of care depending on the type of NCDs that we may encounter. We also need to pilot and scale some public-private partnerships models in urban areas by involving private primary care providers with a continuum of care approach with call centers and e-vendors for dispensing medicines. See, it's very important to recognize that in the urban areas we do not have publicly owned primary health centers, so we have to somehow tap on the available resources of private healthcare professionals there. Then incorporate NCD awareness and screening services in school health programs and adolescent-friendly health clinics under National Health Mission. And I think that's where behavior change will have the most impact, is what I believe. Train the CHWs and informal providers to diagnose and refer care for NCDs, including mental health. Then we also suggest that deploy comprehensive mental health services for targeted groups using digital health tools, and strengthen the supply chain in the public sector to address the challenges arising as a result of shortage of medicines. Because you can't deal with NCDs by only screening or by only vaccines. There has to be an adequate supply of medicines as well. Especially stockouts in public sector impacts its credibility directly. So nobody would want to walk into a public health sector unless he's also provided with medicines. So that's very, very important. Then coming specifically to your point, I think it's important that we advocate and promote the uptake of standardized and evidence-based care for NCDs to bring in uniformity and consistency in the treatment modalities and medications prescribed by different providers. And also develop community-based models for chronic care, treatment, adherence, support, and rehabilitation. I think that's one of the important ways how we can deal with the behavioral change that you were wanting to speak us about. So with this, I'll take a pause here in the interest of time and pass it back to you. Thanks.
Right. Thank you, Dr. Jamil. And I think Dr. Rishikesh, building upon the same conversation, because Dr. Jamil did point out that, how do we, again, your question, he started with integration and you left your point with integration. He gave a, broader landscape of, how do we build on the infrastructure at all levels so that, we move towards, a broader approach towards NCDs, beginning from the primary level, right? So this is what he said. And also another thing for the conversation that we're having right now, NCDs and interplay with vaccination, this is not a conversation that we can have, as a broad level. We need to break it down at a disease level. And that's only when we can have a proper perspective of, why we need to talk about vaccination when it comes to non-communicable diseases. So building upon the same, Dr. Day talked about influenza, and he explained the entire conversation about influenza vaccination. I want to come back to, the hepatitis and the cervical vaccination, cancer vaccination with you, because you have a lot of experience on that front, and specifically when it comes to cervical cancer vaccination, it's been like almost a decade in India. It is still as sort of relatively controversial as it was. It is still, the uptake is still again reluctant, similar to the way it was, because, and not only amongst the masses, but also many HCPs have a very different point of view when it comes to that, right? So when we have such challenges, how do we move forward? Because if these are the challenges, any even new approach or a modality that comes in any kind of, adult or a disease, or a vaccination which is meant for adults, similar problems will come in all of them, right? Because that's how the entire conversation of adult vaccination is, side effects and behavioral issues, etc. So these problems we will face in all adult vaccinations. Right now, I'm contextualizing it in the context of, influenza or hepatitis, cervical cancer or hepatitis. So what do you think? What could be our way forward here,
See, I personally, I'll give you an example. I'm saying a very, good colony here. In one of them, develop herpes. So herpes vaccine is also available. Are you aware of that? After the age of 6, no one knows it. You understand? So first and foremost, the most important thing, we have to take inspiration from our colleagues, the pediatricians. They have made vaccination an excellent implementation, not only in terms of prevention, but it also benefits them financially also. So it's become a part and parcel, an integral part and parcel of their existence. Every pediatrician vaccinates. They help the main aim is to help the children and their parents and the society, and the secondary gain which they get out of it, satisfaction and also some monetary gain, right? So now we have this model in front of us, which is a superb model. That same model has to be applied to the older people. Us, we also got vaccinated when we were bachus. Now we have to get vaccinated like when we were adults. So that starts at 20 years of age with the second booster tetanus shot, the COVID shot, which will also come in. For the women, the rubella shot. For in the pregnancy, the diphtheria, pertussis, tetanus shot, and the influenza shot. After the pregnancy, the hepatitis shot also. Then we have the other shots, like we have the pneumococcal vaccine shot, meningococcal vaccine shot, and then ultimately the herpes zoster shot. This has to be the adult vaccination program. That should be, first of all, we already have met many times. All stakeholders have to sit together and create the adult vaccination program, just like we have got for the pediatric vaccination. That program should be then drilled into the minds of all the healthcare givers. Who are the healthcare givers? The doctors. Who are the main 5 doctor groups in our country? The general practitioners. And we have the 5 associations, the IMA, the Federation, that is the Gynec Societies of India. We have 40,000 gynecologists. Then we have the Surgeons Association, we have the API and the IAP, Pediatric Association. All these 5 associations have to be, of course, pediatrics have their own, they have already worked it out very well. The remaining associations have to come together, and along with the government of India and the state government, we have to create the adult vaccination program task force. And that task force has to implement this program. Then we have to advocate it. Now, the advertisements are all on Rajya Sabha TV and Lok Sabha. Sorry to say, no one sees those TV. Everyone is seeing Colors TV. Everyone is seeing Sony TV. They have to advertise in those television programs. Massive advertisement of health, integrated health advertisement on diabetes, hypertension, vaccination, preventive, contraception, family planning, everything together, integrated all the time. Pumping of advocacy has to be there on social media. And my dad was from Harvard. He was a pioneer of public health in our country, Dr. D.N. Pai. He started the public health department in the University of Mumbai. Fantastic never used to come home before 1 o'clock in the night. As a child, all the time in the slum area. Because why? The entire country stays on the streets of our country. They don't have access to information. Your television doesn't go to them. You have to have mobile clinic everywhere. That, those days when I was a child, what a fantastic program my dad used to have. You have to be proactive. You have to advocate on an extensive scale. You have to drill healthcare into the minds of people. Then only then they will come to you. And they say, Doctor, I want this. Then you have to provide them access. How do you provide access? The doctors, and the biggest weapon. What is the biggest weapon India has got? The 10 lakh ASHA workers. Those have to be trained all the time. The drilling has to be done for the ASHA workers and the nurses. So we have got three groups. ASHA workers, nurses, and we have got, and then volunteers. See, India has a lot of Rotary Club, NGO. See, this health has to be made a way of life.
Right.
Then only, and then I have a vision. What is my vision? That our private practitioners, all of them have come from government hospitals. We all were lecturers. I've spent 15 years in KM Hospital. Okay, serving the poor. And I was an honorary for 17 years in Kurla Baba Hospital, serving the poor. So then we went into private. So our commitment is there to our country. And all the doctors will do that commitment free of charge. We are all good people inherently. So what we need to do, use the private people, and once in a month or twice in a month, our private system should be available to the people free of charge. This is what I'm going to do as president of the federation. I'll say that you give your clinic free of charge to our country. The onus of doing healthcare is not with the government. It is with us, the private people. And that is what the government should do. They should say, you, the doctors of our country, this is the baby. You take care of the health of the country. Why are you making us taking the health care of the country? Health of the country should be taken by us. The government should use us to take care of the health of the country. What is happening? They are poor people. How much they can do? They are taking care of the health of the country. What is the key to that? They have to give us respect.
Correct.
They have to say, "Arey Baba, आप कितने अच्छे हो? ये लो एक award देते आपको." इतना बढ़ेगा ना तो doctors will do anything for the government and for the country. I will just leave you last. I will tell you something. I have been trained by this state free of charge. I have not paid a single penny for my education. I am totally indebted to this country. If tomorrow they will say, take off your coat and tie, I'll remove the coat and tie and give it to my country. So much we are indebted to this country.
Right.
Whatever we are today, majority of the doctors, now they have to pay a little bit for the education, but our time we didn't pay anything. We are totally others. Had the government not supported me, I would have been nobody today. I'm totally obligated to the state. You understand? So you must use that obligation. We are internally so obligated to the state. The government should use that internal obligation and use us for implementing all sorts of healthcare programs.
Right. Thank you, Dr. Rishikesh. And I think it's extremely moving. Each and every single point that you've made, it's really moving. And I hope it moves the audience also who's been watching the program. You said that, government needs to empower people like us, people who are in the private sector. It's government's responsibility, maybe not to, whatever the government is doing in the healthcare, yes, that is their responsibility. But at the same time, also empower. The moment they empower, the ease of service delivery will anyways, begin to materialize. That's one. You said that healthcare has to be instilled in the mind of people. And again, it's a responsibility of everyone who's there in the ecosystem from the side of responsibility. And you started your point from, talking about that how childhood vaccination program and how pediatrics, it's really sort of successfully implemented program in India. And it's been running without any, hassles. And also we have seen major successes. And today in all the panel discussion that we've had, a couple of people, everybody talked about the successes we have achieved in, childhood vaccination. And I think that would be my, due to the paucity of time, that would be my closing question to all of you, that, yes, we have achieved a lot of successes there. And like you said, that we need adult vaccination program. If we see CDC, the website and the entire conversation in US, they already have the whole, structured conversation and policies around adult vaccinations. They have all adult vaccination and everything listed on their website. And, how do we move forward for that? However, I think one of the critical role, or one of the critical aspect in order to move into that kind of direction is the support from the leadership, the regulatory support and the policy support, because childhood programs, they became more successful. One, because it was top-down approach, because it percolated in form of a policy, and the whole implementation followed on that. Similarly, on adult vaccination, it is a much more complicated area. However, that's where the role of leadership becomes much more important. So on that note, I would like to hear, some closing remarks from all of you, that if we now, move towards this futuristic goal of having adult vaccination program for India as well, which will be broad, which will entail so many disease and conditions, how do we look at the role of leadership there? Dr. Dev, we'll start with you on that.
No, I think this opportunity of COVID-19 vaccination program is one of those small windows where suddenly health has become a national priority. And this is the time where we have to look at preventive health programs through vaccination and all other health education, as Paisa told, and that how to educate people, etc. And this is probably the opportunity. I look at this as a green revolution opportunity, or those kind of a scenario that we take this crisis, and probably the whole society has to now realize that health cannot be taken for granted, and we have to work hard, spend money, and be nationalistic. I was quite moved by the inspiring speech by Paisa, that probably this is a moment where people have to realize that we have to take responsibility of our health, and the programs that the government has, they are to be taken forward, and the hesitancy of whatever policies come and programs come, we have got a national character of doubting and suspecting everything that has been told from the state. That needs to go, and we have to look at this as an opportunity to make health as a priority area as all other areas in the society or in our life. Thank you.
Thank you, Dr. Day. And Dr. Emil, your closing remarks, specifically, moving towards a futuristic goal of adult vaccination program and the role of leadership.
Thanks, Nalini. I think we have to prioritize training and empowerment of community health workers and primary health workers as catalysts to reorienting primary health systems to achieve improved patient health outcomes. And I think this is how this has adult vaccination has to get integrated into a primary health system. And not only from vaccines perspective, but from a larger NCD perspective as well. We have to include hypertension screening, screening for diabetes, cancer also. This will ensure a much more holistic approach in our comprehensive primary healthcare program, and will be able to manage healthcare in a much more comprehensive and a cost-effective manner. Thanks.
Absolutely, right. Absolutely. Thank you, Dr. Emil. And last but not the least, Dr. Rishikesh, closing remarks from you.
I'm more, reactive person. These Dr. Day and Dr. Muhammad are very, they are the important people. I think that's the policy makers, we need, but we need the mixture of passion, and we need the mixture of administration also. Yeah. This is what is when I see my dad and all, he was a freedom fighter. He was in jail for 4 years, from 42 to 46. So their passion for the country was tremendous. Then there is a lacune at present. Yesterday also Amit said that in our country, the philosophy of materialism is there, but there was also philosophy of sacrifice. That sacrifice has to come in again, and the sacrifice is very important. The giving is very important. giving not for just giving, acha abhi maine sab kuch kar liya, nahi, giving as a responsibility is very important for all of us. And our countries are just a 70-year-old child here. You know, look at England, 1200 they got democracy. We are just 70. Look at our progress. So we have to be very positive in everything. If our country, our government officials, our secretaries, our ministers, everything, they are fantastic. They are committed. Our NGOs, our public health guys, Dr. Day and Mohammed, they are all representatives. And important is our IHW. See, this is the platform, the IHW Council. This is a break. What we need is, I personally feel there are a lot of interest. There are different vectors. You know, someone is interested in tuberculosis, someone is interested in malaria. What we need is we need to align the vectors. Right. You understand? There's a huge amount of potential, but the potential isn't different. No, naturally, someone is interested in, see, everyone has a interest of self-promotion, but somewhere now we have to say, no. I am not going to take a position. I would like to work. And I'm telling you this, I was telling my wife. I said, after I finish my presidency, I'll still work. I should not work for a position. We need people who will work without the position. Right. This is where our country needs a lot of people to work. And it's an exciting country. It's a developing country. It has huge potential. You understand? So that, you know, it's a great country. Right. So we need to do everything possible. And vaccination is just a part of it. What I have the vision, which I've already talked in the FOMA. We have a Federation of Medical Associations, FOMA, which was propounded by Dr. Agarwal. Unfortunately, he left us in this COVID pandemic. But he had propounded it. We had come together. We have to come together and do it. Otherwise, we can't do it. We can't. See, the problem in India is that there is a bifurcation. There is something internal. Oh, ये तो आप private है. Oh, ये तो हमारा नहीं है. वो तो उनका है. नहीं, हम एक है. हम एक है और अनेक है. ये एक mentality आना बहुत जरूरी है.
Right.
Private people are also part of India, na? They're actually creating. They are evolving our country. They give us the power. So they are part of us. We must use their energy and harness that energy for the development of a country. So it's a larger vaccination. This is a larger thought process, the larger philosophy of our country. It's an evolving country, and it is going to ultimately, our country is in the right direction. No one can dislodge us because we are a democracy, and because we are a democracy, our evolution is slow. It is slow but steady and sure.
Yeah. Absolutely. And thank you so much, Dr. Rishikesh. I think the kind of optimism and the enthusiasm, we see in you, I think that's exactly what is needed when it comes to conversations like the kind of conversation we had specifically, planned out for this particular panel, because this is much more, a conversation which is more futuristic in its sort of, outlook and its approach. And from that perspective, I really thank all three of you for joining us today, giving us the time, to open up a conversation like this, because as opposed to other conversations around vaccinations that we have, more often than not, those conversations are much more established. However, what we need now is that looking at many other disease areas, many other disease burdens that we have, and what kind of scientific advances can be adopted in countering and in balancing the health systems that we have. So I really thank all three of you for joining us today for this particular session. Thank you so much. And with this, we come to a close of the Immunization Summit 2021, where we felt that it is timely for us to come together and brainstorm on the success that we have had on in last 2 years with COVID, but also the success, and to reflect upon the success that we have achieved in last 5 or 6 decades in the country. And with this particular conversation, how do we move forward in the future and look at many other disease burdens that we have in India. And at IHW Council, we will continue to, bring, together many older conversations, but also many new conversations also that needs to be part of our, scientific community here on. So with that, on behalf of IHW Council, I thank all of you and to everyone who's actually joined all the 3 discussions that we had today, and a big thank you to the audience as well for watching this show today. Thank you so much.
Thank you.